Subcommittee will come to order. The chair recognizes himself for an opening statement. In March of this year, the full committee held a hearing on the consequences of Obamacare impact on Medicaid and state health reform. And the Health Subcommittee held a field hearing in Harrisburg entitled PPACA in Pennsylvania, 1 Year of Broken Promises. Again and again, we heard from governors who spoke about how broken the Medicaid program is in their respective states, how it is eating up an ever-increasing portion of their state budgets, and more than anything else, we heard how states want to have the flexibility to tailor their Medicaid programs to the needs of their individual states and citizens. And we heard how they do not want a one-size-fits-all federal framework imposed on them that prevents common sense reforms. The bill before us today, H.R. 1683, the State Flexibility Act, addresses one way that states are prevented from adapting their Medicaid programs to fit their needs, maintenance of effort requirements. Both the 2009 American Recovery and Reinvestment Act, the stimulus bill, and PPACA contain maintenance of effort provisions, which require states to maintain their Medicaid programs with the same eligibility standards, methodologies, and procedures, or risk losing all of the state's federal Medicaid matching funds. H.R. 1683 would simply repeal these MOE requirements and allow states, most of which are facing unprecedented budget crises, to make common sense reforms, including eliminating waste, fraud, and abuse, in order to balance their budgets and save their Medicaid programs. Currently, on average, Medicaid takes up approximately 25% of state budgets, a figure that is sure to rise as 25 million more Americans are made eligible under the PPACA expansion. With MOE requirements in place in order to keep their Medicaid programs from taking over the state budget, states are having to cut Medicaid benefits that are not federally required, reduce provider reimbursement rates, already dismally low, or raise taxes on providers. None of these are good options, not for patients and not for those who treat them. If we do not repeal these MOE requirements, Medicaid programs will continue to eat up funding that used to be allocated for education, highways, parks, law enforcement, and every other function of state government. In my home state of Pennsylvania, the Medicaid program currently takes up 30% of the entire state budget. By the time PPACA's Medicaid expansion is fully phased in, that will rise to 60%. That is simply unsustainable. I commend my friends Dr. Gingrey and Representative McMorris-Rodgers for introducing H.R. 1683, and I urge my colleagues to favorably report the bill out of the subcommittee. And I now recognize my friend from New Jersey, Mr. Pallone, the ranking member, for his opening statement.
Thank you, Mr. Chairman. I want to start with my disappointment in this week's committee process, as I'm upset we're marking up H.R. 1683 without a subcommittee legislative hearing. As outlined in my letter to both you and Chairman Upton last week, regular orders should be followed. The committee should begin consideration of a bill with a legislative hearing in subcommittee, followed by a subcommittee markup before the bill comes to the full committee. And this allows the subcommittee members who have expertise on the relevant subject matter to solicit and synthesize these views of outside experts and the individuals and entities affected by the bill. It also allows for a thorough review and analysis of the relevant policy issues. Today's bill, the State Flexibility Act, would repeal the Medicaid and Children's Health Insurance Program CHIP responsibility requirements enacted in the American Recovery and Reinvestment Act and the Affordable Care Act, which would have devastating effects on low-income women, children, seniors, and the disabled. It's critical that we hear from all stakeholders who represent these populations before moving forward on any potential legislation. I know you said we heard from the state governors in a hearing, but I don't think that that satisfies this requirement. We're here considering another bill that attempts to repeal important provisions of the Affordable Care Act. I guess I had hoped when we moved to the SGR and the malpractice that maybe the attempts to repeal would cease, but obviously that's not the case. The bill today, disguised as giving our states flexibility within the law, does nothing to improve care for Americans. It merely tells states they can kick people off the programs. These protections were designed to prevent states from cutting people off coverage and provide stability to both programs until the full slate of health reform provisions kick in, and now during the economic downturn to also try to protect people in the economic downturn. If these protections are rescinded, the coverage of more than a third of Medicaid and CHIP is at risk. Medicaid was established to serve those with nowhere else to turn. For the last 45 years, it's provided a safety net to millions of Americans in need. It's also the last resort for people who need long-term services and supports. In fact, it covers 70% of nursing home residents and 3 million home and community-based beneficiaries, making Medicaid the primary federal government program for long-term care. Meanwhile, CHIP, a bipartisan effort created in '97, has been nothing but a success story. Because of this critical program, the number of uninsured children in the United States decreased while other uninsured populations grew. Now the Republicans want to allow states to dismantle their CHIP programs entirely, a scenario that is devastatingly clear in the preliminary CBO score. Now, I'm aware of the difficult situation the states are in. Certainly my state is no different. They've had to balance budgets in the wake of decreased revenues and increased need. But cutting health care programs is not the way forward. We must not balance our budgets on the backs of low-income families, children, and seniors. We know the Medicaid program isn't the cause of budget problems. It's the level of unemployment and the lost tax revenues that has caused these fiscal challenges for states. So instead of revoking these MOE provisions, we should be marking up a bill that extends the enhanced FMAP payments to states which expire on June 30th. This was the type of federal fiscal relief that's effective and that was used historically by both Democrats and Republicans in Congress to help states address their fiscal issues, to increase jobs, and sustain safety net programs like Medicaid during economic downturns. I don't understand why all of a sudden FMAP is no longer in vogue. We did it when the Republicans were in the majority. We did it when the Democrats were in the majority. All of a sudden now the Republican leadership has taken that off the table. It's the only answer to the problem for the states, not taking people off the Medicaid and SCHIP rolls. I strongly believe that the true purpose of this bill, which my colleagues on the other side are not going to admit, is the first step towards gutting Medicaid and changing it into a block grant program. These calls to block grant or cap Medicaid under the guise of flexibility and fiscal restraint are short-sighted and dangerous. I know that in the Republican budget that was adopted, that they essentially do this with Medicaid. They make major cuts. I think that what we're seeing today under the guise of flexibility is just another way of moving towards these major cuts in Medicaid that we saw in the budget. I urge my colleagues to oppose H.R. 1683. I think it's very short-sighted and is really going to hurt poor people.
Chair thanks the gentleman and recognizes the Chair Emeritus of the full committee, Mr. Barton, for 5 minutes.
Thank you, Mr. Chairman. I thought we were going to recognize the full committee chairman. Appreciate you bringing forward this legislation before the Health Subcommittee. We're beginning to tell the true story about what our friends on the Democratic side passed in the last Congress. Their big claim to fame was coverage, and we're beginning to see that the way they got that increase in coverage was by mandating these maintenance of efforts at the state level and this huge expansion of Medicaid. If left untouched, this one provision of the new law will literally bankrupt almost every state in the 50 United States. So we're here today to repeal that maintenance of effort. Almost every governor, regardless of political affiliation, has asked for, if not outright repeal, at least flexibility to get around the mandate on this maintenance of effort. As we know, the first stimulus package increased the FMAP percentage, Federal Medicaid Assistance percentage, dollars. In order for the states to receive those funds, they had to maintain that same Medicaid eligibility standard methodology or procedure from July of 2008 to June 30th of 2011. The Patient Protection and Affordable Care Act, PPACA, extended those maintenance of efforts requirements, increased the FMAP funding, but it is set to expire on June the 30th of this year. Congress has now limited states' abilities to manage their Medicaid programs, and we've given states a limited cost boost. Now that states will no longer have the additional FMAP funding, PPACA expands the eligibility requirements for Medicaid, which will greatly expand the number of people participating in the program, adding to the financial burden that states are already facing. In my home state of Texas, it's predicted that the expansion of Medicaid under PPACA is going to cost Texas taxpayers $27 billion additional dollars over the next 10 years. I'm a co-sponsor of this legislation. I think Congress should release the restrictions on the states. We should give them greater flexibility to run their Medicaid program. My own governor in Texas has been very vocal about getting this flexibility. He has indicated that Texas Medicaid costs are increasing about 9% a year. He agrees, he says, Texas, this is Texas Governor Rick Perry, and I quote, "One-size-fits-all approach to health care does not work in the states and imposes unnecessary financial burdens on already strapped state budgets. Now is the time for the federal government to restore states' flexibility to craft Medicaid programs that are tailored to their specific needs," end quote. I totally agree with Governor Perry. I think this bill before us today is a big step in that direction, and I hope that we report it out forthwith. With that, Mr. Chairman, I yield back.
Chair, thanks, Thanks, gentlemen, and recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you, Mr. Chairman. If this bill were to become law, it would slash the number of people that would look to Medicaid and CHIP for their safety net. For 45 years, the Medicaid program has worked as a lifeline to millions of people, providing health care to the lowest income and medically needy Americans. Over the past 3 years, Medicaid and the CHIP program for children served as the health care safety net at a time when we've suffered from the deepest recession since the Great Depression. Since 2008, Medicaid has enrolled 7 million people as they lost employer-sponsored coverage or lost the ability to continue paying their health insurance premiums. During this period, the number of uninsured children actually decreased from 2007 to 2009. This is a testament to the success of these programs. Republicans are now using arguments like flexibility and freedom to make us believe that cutting people from access to prescription drugs, a primary care doctor, a nursing home, and other long-term care is the right thing to do. And I would submit this is precisely the wrong way to go. States are, without a doubt, facing tight budgets, but cutting eligibility to health care is not the answer. In the Medicaid program, the most expensive 5% of enrollees account for more than half of Medicaid spending. And dual eligibles, those eligible for Medicare and Medicaid, account for 9 million people and 40% of total Medicaid spending. States could see a much greater return by managing the care of these high users than by cutting them off the program or cutting their eligibility to services. H.R. 1683 undermines the stability of the Medicaid and CHIP programs and the commitment states have made to their residents for health care coverage. It allows states to cut coverage before the health insurance exchanges make health insurance accessible and affordable for all, at a time when the individual market is still not accessible to sick and low-income Americans. This bill affects some of our country's most vulnerable populations. Kids. This bill would jeopardize the health of 14 million children who are currently receiving coverage under Medicaid and CHIP. Uninsured children are more likely to miss school, to lack immunizations, prescription medications, asthma care, and basic dental care. Pregnant women. Health care is essential to healthy pregnancy. Rollbacks of coverage mean less prenatal care, more high-risk pregnancies, potentially a higher infant mortality rate, and less coverage of deliveries. Rollbacks are particularly dangerous for this group because it is unlikely that a pregnant woman will be offered insurance in today's individual market. The pregnancy would be seen as a pre-existing condition. Seniors and individuals with disabilities. Before I get to that, let me just say that some of the Medicaid provisions to cover children and especially pregnant women were adopted on a bipartisan basis and co-sponsored by myself and Representative Henry Hyde, who was a strong pro-life member of the Congress and who believed that if you're pro-life, you have to help a woman be able to have a healthy pregnancy and also to have a healthy child. Seniors and individuals with disabilities would be hurt. Unlike other categories, seniors and individuals with disabilities have needs that are not easily or exactly met with traditional insurance. For example, long-term care services like nursing home care or care that allows a person to live independently in their homes. These are just some of the populations affected. They exemplify how Medicaid and CHIP have been designed to meet the needs of tens of millions of Americans. This bill is one step in the Republican plan to undermine and defund Medicaid and CHIP. I guess the overall goal is to roll back the expansion in the Affordable Care Act, to cap the level of federal funding available to states through a block grant, and to cut the program in half over the next decade by slashing it by nearly $800 billion. But what this legislation does is undermines access to health care for individuals, resulting in increased uncompensated care for providers. It will hinder economic growth by pulling money out of states' economies. It's a dangerous bill, and I urge my colleagues to vote against it. Thank you, Mr. Chairman.
Chair thanks the gentleman and recognizes the gentleman from Illinois for 3 minutes.
Thank you, Mr. Chairman. This is an important discussion and debate, especially affecting my home state of Illinois. And on March 14, 2011, we sent many of us, myself and the Republican members of the delegation, just sent a letter to our governor asking him, how are we going to do this? How are we going to continue to fund Medicaid, especially with the health care law, which locks in services that we can't afford. Medicaid was created as a voluntary program, and states could participate in with federal government. It was designed to allow states the flexibility to tailor their programs to fit the needs of their citizens around what those states could afford. The maintenance of effort requirement in the health reform law creates a situation where states no longer have the ability to control their Medicaid programs and disregards their ability to afford not making changes that are right for their state. With Medicaid representing a significant portion of every state's budget, this has already forced many states to start looking towards cuts in other areas they can control, as well as raising taxes. We have already seen the effects start in the shape of Illinois, where Medicaid represents over 40% of the state budget. That is already $13 billion in debt. That's the state of Illinois, $13 billion in debt. The state has begun to cut programs and services for the very people Medicaid is intended to protect, with reductions in public health programs, services to elderly and disabled, and education funding K through 12. In addition, Illinois now has a 67% increase in personal income tax that hits every family budget. Just this week, Sears reports considering leaving the state of Illinois because of the increase in taxes. This is on top of 46% bump in the corporate income tax that is companies starting to look elsewhere, as I just mentioned. And despite all this, we have still not received a response from the governor in asking how are we going to resolve this crisis, how are we going to keep businesses in Illinois, how are we going to keep Medicaid solvent. So we see these impacts back at home and heard straight from the governors on their fears. The bill we are marking up today is intended to give them the flexibility to make changes when they see fit to ensure they are serving our most vulnerable populations and meeting their responsibilities to all the citizens of their states. What the governors testified before us is they want the flexibility to be able to handle these services within the constraints of the money that we share with them. They do not have that right now. It's probably time that we give it to them, especially in this problematic period. Again, Illinois has raised income taxes 67%. Illinois has a $13 billion state debt. 40% of that cost to Illinois is Medicaid provisions. If Illinois is ever to get out of this indebted position, it will have to be by reforming the Medicaid system. And with that, Mr. Chairman, thank you. I yield back my time.
Chair thanks the gentleman and recognizes the distinguished ranking member emeritus, gentleman from Michigan, Mr. Dingell, for 5 minutes.
Mr. Chairman, I thank you for your courtesy, and I would begin by stating my respect for you and my denunciations for the legislation before us. H.R. 1683, the State Flexibility Act, would dramatically limit access to Medicaid and CHIP programs in our states. It breaks the promise of affordable health care to our people and the promises made in the Affordable Care Act that we made to the families of this nation. The maintenance of effort provision was included in the Affordable Care Act to assure that the states would not drop low-income adults and children from coverage prior to when the health insurance exchanges are up and running. These provisions were deliberately included in the Affordable Care Act to assure that the states would not roll back their Medicaid and CHIP eligibility as they did in the early 2000s, resulting in the loss of health coverage for more than 1 million low-income adults and children. The CBO projects that 400,000 people will lose their insurance in 2013, and in 2016, 1.7 million children will lose their coverage under CHIP. Cutting people off CHIP and Medicaid does not make the patient well or cause the cost of care to go away. In fact, it just shifts the cost to other patients and to other insurance policyholders, to the hospital systems, and to healthcare providers. There is going to be a cost associated with this that we're all going to have to pay, but a lot of people are prepared to ignore it. Supporters of the bill will argue that it will help to provide some fiscal relief to the state's budget. This is a short-sighted fix to a long-term problem. My home state of Michigan made it through 10 years of falling revenue and rising Medicaid enrollment, demonstrating that it is possible to balance a budget without doing harm to the most vulnerable in our society. I would urge others to learn from Michigan's experience and from its accomplishments in this matter. Instead of pursuing short-term budgetary savings, Congress would be better served to deal with the problems of reducing long-term costs and improve incomes and outcomes. Michigan is also a leader in this field, as they have expanded coverage for pregnant women up to 185% of the federal poverty level. I would note just parenthetically that we rank with the third world in terms of infant mortality, and we are finding that we are seeing a continuing fall in the health of mothers during pregnancy. What we have done is to provide in the legislation that this would repeal, that more high-risk moms-to-be will have access to important prenatal care that will provide for their health during their life, but also for the health and the well-being of their children. States may be able to roll back eligibility to reduce their Medicaid and CHIP costs now, but this all sets stage for greater Medicaid and CHIP costs in the future, when Medicaid expansion takes place in 2014. Thousands of beneficiaries are probably going to be dropped from Medicaid and CHIP rolls if H.R. 1683 is enacted, and will only have to be added back in the system come 2014, when they'll probably be both sicker and more costly to treat. Restoring eligibilities is simply then going to increase costs to the states, but it will cause them to have to increase health care for a sicker population of adult and children's patients. H.R. 1683 is an irresponsible way for addressing the health care access for our most vulnerable citizens, but it is also bad economic policy, and it's going to further strain the federal budget by causing us to misallocate resources and to see to it that when the Affordable Care Act goes into place in full, there will not be the resources available to it being applied as the Congress intended when we passed the legislation. Mr. Chairman, I know you want to work with our governors to help ensure that they can continue to run their Medicaid and CHIP programs while also balancing their budgets. The rest of us do too, but understand that this is a question that we must address with some concern for the sick and the unfortunate amongst us who desperately need to have this legislation rejected by this committee. I yield back the balance of my time.
Chair, thanks to gentlemen. Chair reminds members that pursuant to committee rules, all members' opening statements will be made a part of the record. Are there further opening statements? Chair recognizes the distinguished Vice Chairman of the Subcommittee, Dr. Burgess, for 3 minutes.
Thank you, Mr. Chairman. I think what bothers me most about the issue today is the underlying arrogance in the system. I've seen Medicaid patients. I've worked in the system. I do know firsthand the shortfalls of the Medicaid system, the flaws that have been compounded in the system by the maintenance of effort provisions in both the stimulus bill and the Affordable Care Act. The ability of states to manage their optional populations and to tailor the programs to fit those most at need should be the foundation of the program, and instead the maintenance of effort provision actually ties their hands. Arrogance, to be sure, but what's worse in practice is we hurt the very people that we're trying to help. But how? Well, let me just explain. Instead of encouraging innovation for states to manage their Medicaid dollars, the maintenance of effort provisions have locked states in to procedures and methodologies and forced them to look at areas such as cutting provider rates and eliminating optional services. So I would just have to ask the question, why would you support an outcome like that? In Texas, it's estimated that the total cost of extending both stimulus maintenance of effort for 2012 and 2013 is over $9 billion to retain the current service levels. Now, how in the world does a state face that sort of budgetary hit? To absorb that $9 billion cost, they could cut provider rates by almost half. Now, Medicaid patients currently have trouble finding access to care. Imagine the difficulty that they're going to have if we cut provider rates in half. And this doesn't just affect the new populations that are being affected under maintenance of effort. It actually extends to all Medicaid recipients. Now, it's rare for Secretary Sebelius and I to agree on anything, but turns out that did happen just the other day. And Secretary Sebelius noted that coverage does not equal access, something which I've said repeatedly during the Affordable Care Act debate. She said, and I'm quoting here, "The issue is whether or not by so poorly reimbursing health care providers, you essentially block access to health care so that, yes, you have a Medicaid card, but no one will see you," close quote. That's exactly the problem. So, Madam Secretary, the question is, why support a policy that encourages the lowering of provider rates and therefore decreasing access to care? Now, the Secretary simultaneously puts out a proposed regulation that will encourage states to flee fee-for-service or cut optional services such as dental, optometry, and prescription drug services outright. How is this helpful? Once again, it will negatively impact all of the beneficiaries across the board. So states must decide how to best serve those at the highest needs, and the maintenance of effort by just its very existence harms patients in both access and services. Thank you, Mr. Chairman. I'll yield back the balance of my time.
Chair, thanks, gentlemen. Recognize the gentlelady from California, Ms. Capps, for 3 minutes.
Thank you, Mr. Chairman. I have serious reservations about the bill before us today, the process, or lack thereof, of coming to markup, and the larger attack that the Republican majority has launched on the Medicaid program, the linchpin of our health safety net. Let's be clear. This bill is a stepping stone toward Republicans' true goal of capping the Medicaid program through block grants. We saw this quite clearly on the House floor, where every single one of my Republican colleagues voted for the Ryan budget that ends Medicare as we know it and reduces Medicaid to a shell of itself. These cuts are being made on the backs of low-income families, children, and seniors. It's an extra burden placed on our local governments who will have to deal with the increased level of uninsured. And it's a cruel blow to our community doctors, hospitals, and others providers who will still treat those in need, but not be able to recover any of the costs. Despite what we will hear today, this bill isn't about flexibility. Flexibility is simply a code for, quote, dropping the most in need of care. This includes kids who would no longer be able to see their pediatrician when they get the chicken pox or strep throat, a pregnant woman who would no longer be able to have access to critical prenatal care in order to deliver a healthy baby, and seniors and people with disabilities who will be forced into expensive nursing home care because their home and community-based care is taken away, costing them and taxpayers huge sums, all on our watch. Those are not American values. The purpose of Medicaid is to ensure that those who need it most have access to health care without passing all of the uncompensated costs onto hospitals and localities. It's to ensure the access to care so that individuals can get treatments they need when they first get sick and not wait till their illness is so severe, costly, and difficult to treat. Cutting eligibility levels, or even worse, turning the program into a capped block grant, is foolish and dangerous. The fact that we are even considering it is shameful to me. It's clear that all around the country, state budgets, like those of the American families, are hurting. So while we do need to make tough choices as to how we can put our financial house in order, we really must not do this on the backs of our poor, our elderly, and our disabled. I yield back the balance of my time.
Chair thanks the gentlelady and recognizes the gentlelady from Tennessee, Ms. Blackburn, for 3 minutes.
Thank you, Mr. Chairman, and I thank you and the staff for the good work on this legislation. You know, when it comes to the maintenance of effort, Tennessee has learned some lessons the hard way, and many on the committee have heard me talk for years about those lessons that we learned through the TennCare program. Now, one of the things that we learned very well is that we do not want to see federal legislation and federal mandates that are going to tie our hands, that are going to end up restricting access, and then are going to drive up the cost of that access when our Medicaid enrollees do get that access. As has been pointed out, and Dr. Burgess just pointed it out, what happened in Tennessee with TennCare was when you incentivized use, you gave access to the queue. What you did not give was access to the exam room. And so we have learned very well that lesson, that we need to be thoughtful and we need to be careful. And I am pleased that Secretary Sebelius, after all this time of health care debates, is recognizing how harmful that process can be. Now, what we do want to see is a process and an environment that is going to expand delivery of care and is going to expand that access and provide some certainty that once you have that card, the access to the exam room, not just the queue, is going to be there. So I thank the chairman and my colleagues who have worked on this legislation. We all have had our input on it. I am appreciative that we have had that opportunity, and I yield back my time.
Chair thanks the gentlelady and recognizes the gentlelady from Illinois, Ms. Schakowsky, for 3 minutes.
So I'll try and go this way. Okay. There we go. Thank you, Mr. Chairman. This is the first markup that we've had on Medicaid and CHIP in the Health Subcommittee. We should be discussing ways to get needed health care to Americans who have lost their health insurance along with their jobs or who can't afford costly insurance premiums. We should be working to lower health care costs by improving efficiency and providing access to prevention. Instead, we're here today to consider legislation that will actually take away health care coverage for millions of Americans, children, people with disabilities, and seniors. But throwing people off Medicaid does not make them or their health costs disappear. Uninsured individuals are more likely than those with coverage to go to emergency rooms, the most expensive care, or get sick, and develop expensive chronic conditions. We know all too well what that will mean. Expensive, uncompensated costs to hospitals, worsening of conditions that could be treated early on at less cost, and they will ultimately end up costing taxpayers more money in the long run, unless the Republican plan is to just let poor people get sick and die. Or to quote the speaker, so be it. Normally, we would hear an argument that those who will now be uninsured can go to their community health centers. But given the Republicans' insistence on cutting those centers' funding, that argument doesn't wash. And even if a community health center is available, it won't be able to provide services like chemotherapy, so we're left with the question, where are these people supposed to go? We are probably also going to hear the argument that states need more flexibility. Flexibility to do what? States already have flexibility to reduce benefits. Even prescription drug coverage is optional, and to set provider payments. With the federal government paying an average of 57% of total Medicaid costs, I don't believe it's unreasonable for us to require that individuals not be thrown off Medicaid until the exchanges are fully available, that children shouldn't lose CHIP coverage because it is more affordable for some families. Nor is it unreasonable to prevent states from imposing new administrative barriers to enrollment. Finally, we will likely hear the argument today that states and federal government can't afford to maintain Medicaid and CHIP coverage for Americans because of deficits. Once again, that argument doesn't fly. Seems there's plenty of room in the Republican budget to continue and deepen tax cuts for millionaires and billionaires, to maintain subsidies for oil and gas companies making record profits, to allow corporations that shift jobs and profits overseas to avoid their fair tax burden. If there's room for that, there's room to give mothers prenatal care, children doctor visits, seniors and people with disabilities of all ages long-term care services. It's simply a matter of priorities. For Republicans, it's obviously not a matter of women and children first anymore.
Chair, thanks, gentlelady, and recognize the gentleman from Georgia, Dr. Gingrey, for 3 minutes.
Mr. Chairman, I want to thank you for calling today's markup on H.R. 1683, the State Flexibility Act. I'd also like to thank you for your willingness to support this important legislation. Additionally, let me thank my colleague from Washington State, Kathy McMorris-Rogers, as well as full committee chairman Fred Upton, Greg Harper, and Leonard Lance for their work in authoring the legislation. Unfortunately, due to both the American Recovery and Reinvestment Act, the Stimulus Act, and the Patient Protection and Affordable Care Act, Obamacare, we're leaving states with zero flexibility by placing on them Medicaid eligibility restrictions known as maintenance of effort. These restrictions bar states from implementing simple waste, fraud, and abuse programs under Medicaid. During this unprecedented budget crisis, governors are desperately asking the federal government to give back what was taken from them by the last Congress, Medicaid flexibility. In my state of Georgia, our governor and former colleague on this committee, Nathan Deal, sent me a letter yesterday supporting this legislation and reminded me of the constraints that my state of Georgia is currently facing. He wrote, and I quote, "With little flexibility, we're finding it almost impossible to protect patient access while ensuring the financial solvency of our program. Since maintenance of effort requirements demand that the state of Georgia must maintain our Medicaid and S-CHIP programs with the same eligibility standards, methodologies, and procedures, the only options available to balance our Medicaid and CHIP budgets include what? Increases in participant cost sharing, reducing provider reimbursement, and eliminating coverage for optional benefit categories." Mr. Chairman, Governor Deal's letter of support shows the critical need for this legislation to be enacted. Since most states are compelled by their state constitutions to balance their budget on an annual basis, MOE compliance prevents states from implementing common sense Medicaid enrollment modernizations, and a failure of compliance means, you guessed it, a state loses all federal Medicaid matching funds. H.R. 1683 corrects this problem by repealing these onerous Medicaid maintenance of effort restrictions, and it restores the long-standing partnership between the federal government and our states. Additionally, the nonpartisan CBO office has scored this bill as reducing our deficit by $2.1 billion over the next 10 years. And furthermore, the CBO estimates that the legislation could save states approximately $2.5 billion within that same budget window. Mr. Chairman, the Medicaid program has historically been a partnership between the states and the federal government, where states could manage their enrollment in a way that meets the needs of their citizens and keeps their budgets balanced. H.R. 1683 helps states continue to ensure this partnership by ending onerous maintenance of effort requirements. Therefore, I ask that my colleagues support our governors by supporting H.R. 1863. Mr. Chairman, I ask unanimous consent to enter into the record letters of support for this bill from Americans for Prosperity, Let Freedom Ring, Americans for Tax Reform, Citizens Against Government Waste, and Governor Nathan Deal from the great state of Georgia. Furthermore, I'd like to submit 2 letters that contain the signatures of all 50 governors urging repeal of the maintenance of effort provisions currently burdening state Medicaid programs. And I ask for unanimous consent.
Reserving the right to object.
If you'll pass those down, please. Chair thanks the gentleman and recognizes the gentlelady from...
Mr. Chairman, I had a reservation on his...
Yeah, we're going to let you take a look at it first. Recognize the gentlelady from Wisconsin for 3 minutes, Ms. Baldwin.
Thank you, Mr. Chairman. This bill is deeply troubling to me. Let's be forthright about what this bill could do in our states, in Wisconsin, and across the nation. It could kick our most vulnerable citizens, including patients with cancer, women who are pregnant, people with disabilities, seniors in nursing homes, off their health insurance and leave them without access to affordable health care or coverage. States could scale back or even entirely eliminate the children's health insurance program, leaving kids with everything from ear infections to cancer without health care coverage. And states could refuse to provide coverage for parents and non-disabled childless adults over 34% of the federal poverty level with health care. Mr. Chairman, we often throw around numbers without thinking about what they really meant. So let's explore this in a little more depth. 34% of the federal poverty line. This means that if a Wisconsinite makes more than $3,702 a year, $3,702 a year, the state could refuse to provide health care coverage. That is morally reprehensible. We know that there could be immediate consequences in many states, including Wisconsin. Should this bill become law, it would allow our Governor Scott Walker to make the very steps that he outlined in his budget adjustment bill earlier this year that significantly alter, I'd say even gut our Medicaid program by eliminating insurance coverage to up to 63,000 Wisconsin parents and 6,800 childless adults. Moreover, this bill could open the window to allow the governor to make even more drastic changes to one of our Medicaid programs, Badger Care. Now, even though it pains me to do so, let's just set aside the moral reasons to protect our vulnerable neighbors for one moment. Proponents of this bill have asserted that repealing the maintenance of effort provisions is necessary given immediate state budget problems. What these same proponents fail to recognize is that this is not a plan that will save states money. Rather, it would simply shift costs and result in very expensive consequences. When individuals are uninsured, they are much less likely to seek preventative care. They are more likely to delay needed medical care and more likely to seek treatment for what would have otherwise been avoidable illnesses in costly emergency room settings. This results in higher uncompensated care costs for hospitals, which in turn increases medical bills and insurance premiums for families and small businesses. I really fail to see how this will help states or families recover from our severe economic downturn. Mr. Chairman, if our goal is to help states that are struggling at this time of economic downturn, let's focus on productive solutions that will create jobs and bolster the economy. I urge my colleagues to oppose this morally and fiscally flawed policy that will leave our vulnerable neighbors without access to health care and stunt our nation's economic recovery. Thank you, Mr. Chairman, and I yield back.
Chair thanks the gentlelady. Recognizes the gentlelady from Washington, Ms. McMorris-Rogers, for 3 minutes.
Thank you, Mr. Chairman, and I would like to thank you and Dr. Gingrey and Chairman Upton for all of your work on this legislation. And at the beginning here, I'd like to enter into the record a letter that is a consensus letter of the National Governors Association. It is signed by Governor Gregoire from Washington State, who is the chair, Democrat, and Governor Dave Heineman, who's the vice chair, Republican. And I want to read just a little bit from this letter. They start out and say, as the new Congress convenes and a new year begins, the national governors call on the federal government to work cooperatively with us to reduce deficits, restore fiscal discipline, and promote economic growth and long-term prosperity. One of their principles that they highlight as a way of moving forward in this effort is Congress should not impose maintenance of effort, MOE provisions, on states as a condition of funding. MOEs curtail state authority to control their own budgets and fiscal systems, and over time discourage investments in state federal programs. When it comes to Medicaid and most issues, I'm not reading from the letter anymore, the government closest to the people is the best form of government. States have long been laboratories of democracy and innovation, identifying policies and practices that assist and empower individuals, including the most vulnerable and the poor among us. The State Flexibility Act follows this principle, facilitating the development of new ideas for the best healthcare decision-making. This last February, I sat down with Washington State Governor Christine Gregoire, who's the current chair of the National Governors Association. And the first thing she said to me was, Kathy, we need flexibility. We need flexibility in eligibility, flexibility in services, and flexibility in reimbursements. What many don't realize is that the current MOE is harmful to our most vulnerable populations, and I want to explain why. When Washington State was experiencing surpluses, the Medicaid eligibility rules were expanded to include individuals who had incomes well above the federal poverty line. Individuals, frankly, who should have been covered in the private market. Yet now the state finds itself facing a projected deficit of $5.2 billion, and the governor can't do anything about the main cost driver, Medicaid. She's already put programs and services such as the Disability Lifeline program that are critical to our most vulnerable populations on the list of those to be cut, because the strict eligibility mandates imposed by the federal government provide Washington State no flexibility and prevent her from making any other choices. This is unacceptable. The State Flexibility Act will give states the flexibility they need to keep Medicaid available to those who truly need it, the poor, the elderly, the disabled, poor women and children, while avoiding the cost that will force the program to spiral out of control. I urge my colleagues to support this bill and yield back the balance of my time.
Sure, thanks, gentlelady. If you'll pass down that letter, I'll let the ranking member take a look at it, please. Chair recognizes you have hers. You don't have objection to that? No. All right. Without objection, that unanimous consent request be granted. Letter be entered in the record. You're taking a look at those. Yeah. Chair recognizes the gentleman from New York, Mr. Weiner, for 3 minutes.
Thank you, Mr. Chairman. And first, let me just clarify. Mr. Gingrich said this letter was signed by all 50 state governors. That's not correct. Only 2 state governors signed it. But let me just say this. You know, I'm dying.
Would the gentleman yield?
I only have 3 minutes.
I'll just very quickly say I never said it was signed by all 50. I said it was a consensus letter.
Mr. Gingrich said it. Let me just say this. First, I'd love to introduce the Republican Energy and Commerce Committee members of May 12th to the ones of May 11th. They were the ones saying we needed to have national standards for tort reform with no ability of governors to waive, no ability of legislatures to waive, because it's important that you have mandatory nationwide programs for torts, and now you're saying it's not necessary to have them for Medicaid. It's not the first time there's been this inconsistency. We have heard people in this chamber, in this room, howl at the moon at the fact that the administration has offered so many waivers on Midi-Med programs. Inflexibility, you were complaining just a couple of weeks ago how they were being too flexible. And for those of you who were asking about let's have selling of insurance over state lines, you apparently then believe there should be a national regime and no state regime. Look, I understand that you're having a difficult time, and I hope your health insurance also covers you getting tied in intellectual knots trying to figure out ways to argue against health care reform. But the fact is very simple. The reason you have the maintenance of effort in place is because starting in 2014, when the exchanges are in place, the federal government pays all of the additional costs The states pay none of the additional costs. So the reason you have the maintenance of effort is to prevent the states dumping people off in anticipation of them coming back on when the federal program kicks in. It's smart policy. It's policy that if you were serious about legislating on health care reform, you would include in your provisions as well. And let me just say something else here. The fact is that you can say tomorrow we'll have no Medicaid. That's your objective. It's pretty clear. You clearly want there to be no Medicare. That's your objective. I've read the Ryan book. Made my hair hurt reading it, but I read it. But the fact is, it doesn't mean that nobody pays the bill. Who pays when someone gets sick, when a poor person gets sick? Who do you think pays for it? What is your plan to pay for those people? Oh, let's give them a voucher. Let's, when they're hit by a bus, lying on the street in your town, let's roll up a little voucher and put it in their belt buckle and say, you're on your own, buddy. That's not the way it's going to work. So this is why Medicaid was created. This is why Medicare was created. It comes as no mystery to anyone watching this debate. There were programs created by Democrats because we're serious about providing health care for people and serious about figuring out a way to do it in a reasonable way. Now, you say there's this partnership between the states and the federal government and Medicaid. That's true. There isn't a single of the 50 states that hasn't gotten at least one waiver for some element of Medicaid. Frankly, Democrat and Republican executive branches alike have always encouraged states to experiment. I'll make one final point. When we say maintenance of efforts, we're saying today's state laws passed by the governors and the legislatures of the 50 states. We're not saying substitute the geniuses in this room for them. So the idea of maintenance of effort is maintain the state autonomy. That's something that we should be consistent on. Thank you.
Chair, thanks. Gentlemen, are there other opening statements? Recognizes the gentleman from Pennsylvania, Dr. Murphy, for 3 minutes.
Thank you, Mr. Chairman. The damage that the Affordable Care Act will have on Pennsylvania's Medicaid recipients is too much to ignore. Somewhere between 600,000 and 800,000 Pennsylvanians will be added to Medicaid under the new law, costing the Commonwealth between 100 and 150 million in additional costs each year. For a state that's expected to run a $4 billion shortfall in this fiscal year, an extra $150 million is unsustainable. Now, Pennsylvania is not alone. In March, when the Health Subcommittee held a hearing on the cost of the Affordable Care Act on state governments, Mississippi Governor Barbour told us that he estimates the state will be forced to pay an additional $400 million in Medicaid costs each year, increasing the state's annual deficit by close to 70%. This issue of Medicaid did not fix the poor's health care needs. It did not finance this health care provision. It did not fix the waste and inefficiency in this program designed in 1965. Those issues must still be addressed, but what was done does not fix the problem. Some may contend that ensuring access to care is worth the extra deficit spending, but due to the health care law's maintenance of effort requirements, states will be cutting provider reimbursements and reducing benefits to offset the additional burden. How does that solve the problem? In fact, it's already started. Due to the 2009 stimulus law's maintenance of effort requirements, over 41 states cut provider reimbursements. The Affordable Care Act will force states to make cuts elsewhere in the health care system, resulting in less quality health care and less access, less physicians, and less treatments. I support the State Flexibility Act because it repeals the federal government's stranglehold on state deficits and allows states to balance their budgets while maintaining quality care for Medicaid beneficiaries. What is immoral is handing each man, woman, and child in America a bill for $45,000, their share of the national debt. What is wrong is increasing our debt by $58,000 per second, spending it faster than you can say it. What is wrong is telling states through mandates they have to provide the Medicaid and then tells them they're going to have to find a way on their own to pay for it. What is wrong is not reforming Medicaid, so we still have a system that's designed in 1965, as I said. Now, we've done things in this committee where, for example, my friend Mr. Weiner, in a tongue-in-cheek way, said, let's just get rid of Medicare. We all know that's not the way to do this. We can't just get rid of Medicaid. We know that there is a need out there, and we want to help the poor. We want to help them with health care. Believe me, I've seen my share of patients who are covered by this program, and I've been a supporter of things like this and the CHIP program to make sure we're out there doing that. But we've got to find a way of reforming this system and making it work better for states and not just pointing fingers and say that those who want to make it work better don't care. I believe both sides of the aisle care deeply about those who are of low income and needy. We can fix this, but this is not the way to do it, and that's why this bill needs to be repealed. I yield back.
Chair, thanks, gentlemen. Recognize the gentleman from Ohio, Mr. Latta, for 3 minutes.
Well, thank you very much, Mr. Chairman. Appreciate the time. And I rise in support of the State Flexibility Act. And I think it's important to go back just a little bit as to what Mr. Barton was saying in the letter that was sent by the 33 Republican governors and governors-elect in their letter of January of 2011. Especially when they're talking about the maintenance of effort provisions of the American Recovery and Reinvestment Act, the ARA, and the Patient Protection Affordable Act. So, you know, they state in this letter that it prevents states from managing their Medicaid programs for the unique Medicaid populations. It goes on to state that if they need to have the flexibility to control their program costs and make the necessary budget decisions. And that's important because for those of us that have been in state legislatures, and we also understand that we have a situation out there that most of all of us have in our constitutions where we have to balance our budgets. The National Governors Association is quoted in this letter saying that when it was released last month, which had been December, of the fiscal review of the states, it goes on to say that one of the clearest signs of the state fiscal stress are mid-year budget cuts as they highlight the difference between budgeted levels of spending and forecasted revenue collections. And just in the year of 2010, 39 states made $18.3 billion in mid-year budget cuts, a lot more than we did here when you look what we were doing last year. It goes on to state that the health and education are the primary cost drivers for most states, and the states aren't able to afford the current Medicaid program. Again, in my home state of Ohio, we started this fiscal year, and we do our biennium budget this year. They have almost $8 billion in the hole that they had to make those cuts. And then I know Governor Kasich in Ohio and the governors across this nation are asking for some flexibility that they be given so they can make sure they can control these costs to carry on these very, very vital needed benefits. And with that, Mr. Chairman, I urge support of H.R. 1683 and yield back the balance of my time.
Chair thanks the gentleman. Are there other opening statements? Seeing none, the chair calls up H.R. 1683.
Mr. Chairman, could I make this unanimous consent?
Yes,
I know that,
go ahead first.
I know that we had I guess Mr. Waxman had reserved on the Gingrey series of letters, and I think that we've seen them now, and so I would ask, did you want to withdraw? We can say that we'll accept the unanimous consent on those. And then we had a series of 5 letters in opposition to H.R. 1683, which I gave to you or to your staff, and I would ask unanimous consent to include those in the record. Yes.
Because I was going to wait later to do it, but because we received also a letter from the American Nurses Association strongly opposing H.R. 1683, the State Flexibility Act of 2001, and urging us to vote no when it comes before the committee. So I would add these to the letters to be introduced to the record.
And that's one that you've already seen as well. So I'd ask unanimous consent for that and the other 5.
All right. Without objection, so ordered. All letters from Dr. Gingrey and from the ranking member, Ms. Capps, are entered into the record. Chair calls up H.R. 1683 and asks the clerk to report.
H.R. 1683 to report.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Are there any bipartisan amendments to the bill?
What does that mean? Bipartisan?
That's the rule the chair asked us to consider first. Okay. Are there other amendments to the bill?
Yes, I have an
Mr.
amendment.
Malone is recognized.
We can say it's bipartisan if you like, but I don't think you'll agree. I guess I just have one amendment at the desk.
The clerk will report the amendment.
An amendment offered by Mr. Pallone of New Jersey.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. My amendment is quite simple. It protects children from the harms of this bill by exempting them from the repeal of the maintenance of effort in Medicaid and CHIP in both the Recovery Act and the Affordable Care Act. The choice, I think, is clear and simple. You either support the care of children or you oppose the care of children, because without these protections, this nation's children are very vulnerable. I want to offer for the record a report by Georgetown Center for Children and Families titled Eliminating Medicaid and CHIP Stability Provisions, What's at Stake for Children and Families. I believe we've given you that. I'd ask unanimous consent that that be included.
Without objection, so ordered.
Now, this report rightly concludes that if the stability protections included in the Affordable Care Act are rescinded, it could have a dramatic impact on many of the low and moderate income children, families, seniors, and people with disabilities that rely on Medicaid and CHIP. It could also unleash cuts in health care spending that weaken the pace of economic recovery and job growth. Medicaid and the CHIP program cover nearly 30 million, or one-third of all America's children, and over half of low-income children. Medicaid and CHIP provide children with comprehensive medical services to address physical, mental, and developmental health needs. Children represent half of all Medicaid enrollees, yet they account for only 20% of the spending. Through Medicaid and CHIP, the country has successfully reached the highest rate of insured children on record. 90% of children in the United States have health coverage. If the maintenance of effort is repealed, the coverage of more than one-third of Medicaid and CHIP beneficiaries will be threatened. And children are the single largest group of beneficiaries that will be at risk if the stability protections are repealed, even though they're the least expensive population to cover. And I'll stress that again, Mr. Chairman. They are the least expensive population to cover. According to the Center for Children and Families, there are an estimated 14.1 million children covered at state option through CHIP or Medicaid, all of whom will be at risk of losing coverage. If the MOE is repealed, states could shut down new enrollment in the CHIP programs, roll back CHIP eligibility, or completely eliminate their CHIP programs. And such potential loss of health insurance has dire consequences on the health of children. Let me give you examples. Uninsured children are 20 to 30% more likely to lack immunization, prescription medications, asthma care, and basic dental care. Uninsured children with conditions requiring ongoing medical attention, such as asthma or diabetes, are 6 to 8 times more likely to have unmet health care needs. Uninsured children are also more likely than insured children to miss school due to health problems and to experience preventable hospitalizations. According to CBO, the legislation before us will cause 400,000 people to lose their insurance in 2013, with about 300,000 of them unable to find other coverage, and two-thirds of those would be children. In fact, according to CBO, by the end of 2016, half of the states would cease participating in the SCHIP program. This repeal would throw 1.7 million children out of a program that's proven to work in 2016 alone, and this is a program created with bipartisan support. I don't know what happened to the Republican Party. This was done on a bipartisan basis. I was here. Mr. Waxman, others were here. You were the ones that initiated this along with us. So why do you want to kill the CHIP program? This 1.7 million children, about 30% of projected enrollment in that year, 2016, would become uninsured. In addition, cost-sharing protection and employer-sponsored insurance and qualified health plans is less protective than CHIP. I can't emphasize enough, Mr. Chairman, that coverage for children is much cheaper than that for other kinds of people, and it is very cost-effective. It costs 234% more for an emergency room visit than a doctor's office, and an uninsured child is 500% more likely to use an emergency room as a regular place of care than an insured child. Let me just summarize again. The rescission of stability protections would be devastating to the children, to our country. I don't think we should be balancing the budget on the backs of children. I just urge my colleagues to make the right choice, to vote aye on this amendment. Children should be exempted. We worked for many years on a bipartisan basis for this CHIP program. Don't throw it away. And I know you're going to say you're not, but that's what you're doing. And certainly the CBO report indicates that. And I don't want to keep saying the same thing again, but I just, I always worry that because kids don't vote and they don't have a constituency and they don't have a lobbyist, that that they're just put aside. I'm not saying that you're doing that, because I wouldn't want to accuse anybody of that, but I do think that somehow over the years this concern for kids is being lost, and I just think it's a shame. Thank you, Mr. Chairman.
Thanks, gentlemen. Is there discussion on the amendment? The chair recognizes the gentlelady from Washington, Ms. McMorris Rogers, for 5 minutes.
Thank you, Mr. Chairman. No one is suggesting that we kill S-chip. I believe you just said that.
Well, I don't want to take away from your concern for kids, but I
with
just
all
want
due
to
respect,
point out the facts.
I'm reclaiming my time. I want to make some points. The S-chip program maintains broad bipartisan support. I oppose this amendment because the bill doesn't change the eligibility of any population, including children. I would ask my colleagues, how is adding an additional 25 million people to the Medicaid rolls strengthening a program for children? What I would say is that the expansion actually diminishes the proper coverage for those most in need. And I want to just remind members of the committee, mandatory coverage, which is not changed in this bill, includes pregnant women during pregnancy, infants under 1 year of age whose family incomes do not exceed 133% of the federal poverty level, children between 1 and 6 years of age and family incomes who do not exceed 133% of the federal poverty level, children between 6 and 19 years of age whose family incomes not exceeding 100% of the federal poverty level, the SSI recipients of adoption assistance and foster care. This bill does not change the mandatory coverage of the categorically needy groups. I support the safety net provided through Medicaid. What I oppose is promising health care to many who will never see it at the expense of those that are truly in need. The gentleman from New York says that the federal government is going to pay the entire cost of Medicaid after 2014. It's a false promise. First of all, it's a temporary payment. Second, I would suggest that the government doesn't pay the cost. We all know that Medicaid, that it's the providers that continue to have to pay more and more of the cost of actually delivering these services, because the government, whether it's the federal or the state government, is not actually paying the bill, isn't paying the cost of the program. And the providers are put in a situation where they cannot afford to give the services, provide the services. And what it does is when you are on Medicaid, it is harder and harder to find a provider that will actually take you because we're not paying the bill as it currently is. So if we're honest with ourselves, if we truly want to maintain the safety net for those that are most in need, we will allow the states to be making those decisions. And we will allow them the flexibility that they need to ensure that those that are most in need get the services. So I would...
Will the gentlewoman yield... If you're done, I didn't. I know you're a mother, and I know you care about children. I'm not suggesting otherwise, and I'm not suggesting that about anybody on the other side. I'm just saying that practically speaking, I know that everyone on the other side cares about kids and feels that somehow, if this bill passed, that they're still going to be covered, they're still going to get the proper care. I just think that practically speaking, though, you really haven't come up with an alternative. In other words, you're saying, I don't like what the Democrats did. You know, let's get rid of this. Let's have state flexibility. But I think the CBO shows, and I know, I don't always believe in the CBO, but the CBO numbers show that practically speaking, 2/3 of the kids are going to be gone. They're just not going to get the coverage. And I just don't think you guys have come up with an alternative to show us in a practical way how we're going to achieve coverage and get these kids care. That's my concern, and that's why I'm proposing this amendment.
Well, in response, I would say that the governors, Republicans and Democrats, have asked for this flexibility so that they can really make decisions at the state level that are going to best serve the population that we all want to help, whether it's the poor, elderly, children, developmentally disabled. And what the federal government has done is impose mandates on the states that take away their flexibility so that they can't even make decisions that are in the best interest of those populations. And CBO, with all due respect, I am not sure that they can assume, I know that they try to project as much as they can, but I'm not sure that they know how the governors are really going to respond to this legislation. There is bipartisan support for ensuring that we have this safety net moving forward. And what the governors have asked is the flexibility. And as I mentioned in my remarks, Washington State, for example, proposed to cut the disability lifeline this year because of the mandates in the legislation that passed last year that would not allow them to make a decision to keep that program. So that's why I...
Chair, thanks, gentlelady. For what purposes, the gentleman from New York seek recognition?
I thank you. And I look, I respect this debate. But
you want to strike the last word?
Certainly. Strike the last word.
Just for 5 minutes.
Thank you. You know, let me just show how this is being characterized. This is not just a squabble here. There's a difference of philosophy. I mean, this is the way CQ Quarterly reported it today. CBO says new Medicaid bill will leave many children without coverage. That's their assessment. And the irony is on the very next page it says GOP freshmen decry attacks on their plan. There's got to be some recognition of the idea that what Mr. Pallone is saying is right. CBO stipulates to the idea that the gentleman from Georgia and the gentlelady from Washington say that this amendment is going to save the federal government money. But you can't have it both ways. You've got to understand the way it's going to save money is essentially reduce the number of people getting coverage. That's the bottom line, and they're children. And if you were really going to be honest about this discussion, all of these amendments that you have would include some answer to the question how you increase coverage, how you make sure people are covered. Now, let's remember something. What the gentlelady from Washington said about my remarks earlier, in 2014, when the federal government accepts full funding responsibility, not 60% or 80% as it is in Mississippi, full funding, it's because they say what we want to do is increase the number of people being covered, and unlike what happened in Republican administrations, we're not going to have an unfunded mandate. We're going to accept responsibility on the part of the federal taxpayer to do what this federal thing does. You guys do the opposite with this amendment. You save money for the federal side, and then you leave the states to try to figure out how these people are going to get covered or uncovered. We need to have some level of standards. We have to make sure there's not a race to the bottom. And Washington State has had several occasions apply to the federal government for waivers under some of the Medicaid rules so they can experiment in different ways, and that's the way that it should be. But you can't decry the attacks on your health care plan when, in fact, you're trying to defund it and you're doing it in a way that leaves at least two-thirds of the 300,000 people affected will be children. I mean, how are you going to cover them? What's the plan? Tell us the plan. Now, the gentlelady from Washington says, I don't have a plan. I'm going to leave it up to the governor to have a plan. Okay, that's very nice of you. You want to have no requirements and you want to hope for the best. Well, we've seen what happens. What we see is a country that has about 40 million people that are uninsured. You have hospitals that are closing. You have people that have higher taxes in the states and localities because we aren't doing something the way we should, which is saying, you know what, the same way we address the safety net for seniors under Medicare, you're trying to dismantle that. We now created a system of a safety net for Medicaid, and we're trying to grow it every day to close the gaps in that safety net. And you're saying, no, let's slash some more holes and let children fall through it. So what is your proposal? You know, the thing about the repeal and replace that had some appeal to me is you were going to offer something for the first time, really something to replace the things you're repealing. When are we going to see that, I say to the gentlelady or the gentleman from Georgia? When are we going to actually see what the proposal is to deal with the 300,000 kids that are going to be falling off the rolls here? I mean, you can't just hope and pray that the health care fairy will come down and put pixie dust, and that's the way it's going to happen. It hasn't worked that way. And so what the system is that we've worked out is pretty simple. People are going to be required to get insurance, so people can't freeload, but we're going to give them a subsidy and incentives to go get it. We're going to create the system for poor people that hasn't really kept up. We're going to raise that floor substantially, but we're not going to let the states just pick it up. The federal government's going to pick it up. The next thing that we're going to do is we're going to make sure that people have the opportunity, that insurance companies really have to compete by having minimum standards and saying, you know what, we're going to create an exchange like we have in the federal government. This is our plan for trying to do it. Now, as you throw darts at it, and people say, well, and then you decry anyone for criticizing it, come up with your own plan. You've now been running the shop here for a few months. Let's see what you actually plan to do. The CBO, which you like, sometimes you don't like, sometimes you don't like. I understand. I've been in Congress a while. I understand we like the CBO when they agree with us. We dislike them when they disagree with us. But at least put something on the table that
Would the gentleman yield?
Certainly.
First of all, I want to remind...
I don't think you're going to get a second. So
okay, I'll just say the mandatory requirements in this are not changed in this legislation. Second, I would remind my colleagues on the other side of the aisle that their proposal doesn't fund SCHIP after 2015. It's up to the states to figure out how they're going to pay that bill. And yes, we do have a plan moving forward on Medicaid. We want to make sure that we have a safety net and then we want to be providing more options to families, to children, to individuals.
When you
so that
say
they
more
can have
options,
affordable-
if I can reclaim my time, first of all, it's not like we go to zero reimbursement rate in 2015. That's not right. We just don't do 100%, but we still are in the magnitude of 90-95% for years to come after that. Secondly, here's what I would say.
The gentleman would yield us Medicaid, not S-chip.
Secondly, what I would say is this, is that there is going to be a point that I think something is going to happen as a result of this bill. I hope CBO says it's going to happen and common sense says it's going to happen, that more people are going to get covered. The economy is going to do better since we're not all paying health care bills, and hopefully fewer people are on Medicaid and S-chip. That's the objective, but at least our bill sets up some kind of a platform to do it. I would welcome you to offer one that accomplishes any of those things. Up to this point, there hasn't been one.
Okay.
You know, any jackass can kick down a barn, but it takes a pretty great woman to build one. Let's go ahead and build one.
Chair thanks the gentleman. The gentleman's time has expired. Recognize the gentleman from Georgia, Dr. Gingrey, for 5 minutes.
Mr. Chairman, thank you. And, of course, I'm very much opposed to the Pallone amendment. My colleague that just spoke, our friend from New York, talked about, well, you Republicans, what is your plan? Well, it looks right in front of you. It's called the State Flexibility Act, H.R. 1683. That's our plan. Our plan is to allow our governors to, you know, if they wanted to, as let's say the state of New Jersey wanted to increase their coverage, Medicaid or S-chip, up to including families making $90,000 a year for a family of four, heretofore, before the provisions of the stimulus plan and Obamacare, under 1115 waivers, they could do that. And all we're saying is take the handcuffs. Why put those handcuffs on the governors? Why not let them go back to the way it was? And if they decide, I don't think in their infinite wisdom, to cover people making $90,000 a year and their children, so be it. Let New Jersey do that. Let New York do that. Let them cover people making $150,000 a year. I mean, you know, maybe in those states it's politically correct to do that. But quite honestly, in the state of Georgia, politics aside, we can't afford that. And these letters of support from so many governors, both Democratic governors and Republican governors, just simply say, you know, we can do, maybe we are our state that expanded our coverage beyond the mandatory coverage in the Medicaid law that was enacted way back in 1965, along with Medicare. Maybe in times of prosperity, when we decided to expand our coverage to people making $50,000 a year, that was great. But now we can't. Now we can't. The only way we can continue to cover people that are, you know, not rich, but they're certainly not at a poverty level, the only way we can continue to do that is to cut benefits, to cut some of the optional things like dental care and the early and preventive screening, diagnostic, and treatment program for children. And so, as Mr. Weiner said earlier, something about, well, you might as well have a voucher. Well, you know, what good is it to have a Medicaid card if not only the coverage is poor, it's bargain basement health care coverage, and even worse, you can't find anybody to provide that coverage, that inadequate coverage. So, you know, quite honestly, I think in response to, as I've already said, in response to the suggestion from the gentleman from New York about what is our plan, this is a simple plan. This is just simply saying, we heard all day long yesterday when we were debating the Medical Liability Reform Act, you know, why not use these pilot programs? Why not let the states be the incubators of reform? Well, why not let the governors in the states be the incubators of reform in regard to taking the handcuffs off them so they can save the Medicaid program, so they can save the CHIP program? That's all we're asking.
Will the gentleman yield? I'll be glad. I just want to make sure I heard the gentleman say, perhaps with irony, that what's the use of giving someone a voucher if they can't afford affordable care and it's not of a certain quality?
Well,
Congressman Ryan,
reclaiming my time. It is my time. I'll have to admit to the gentleman from New York, when I'm trying to make a lot of points and get it all said, sometimes I speak as quickly and as rapidly as the gentleman from New York, and I might misstate a word or two.
Fair enough. But would the gentleman yield to me?
I'll be glad to yield to the author of the amendment.
The bottom line is, though, right now states have a lot of flexibility. They can change the benefits. They can decrease benefits. They can increase co-pays. I mean, I don't want them to do these things, but that flexibility exists. The problem is that once this bill passes, they actually could not provide insurance at all for a lot of these kids, okay? And that's what I'm trying to avoid.
Well, reclaim my time and thank the gentleman from New Jersey for his point. But what they end up doing, of course, to make sure that that doesn't happen, our governor of Georgia, our former colleague, Nathan Deal, former chair of the Health Subcommittee, served 20 years in this body, a distinguished member, he won't do that. He doesn't want to do that. But you know what he had to do? No, I won't yield. My time's about expired. He had to cut funding for K-12 education, for public safety, and first responders. That's what our governors are faced with. That's why I am so opposed to this amendment that the gentleman has offered, and I ask my colleagues to vote no.
Thanks, gentlemen, and recognize the gentlelady from California, Ms. Capps, for 5 minutes.
And I'll go to you. Thank you, Mr. Chairman, for yielding to me, and I think the discussion that we're having underscores the very value of Mr. Pallone's amendment. We're anticipating what it would mean to have millions of children pushed into the ranks of the uninsured at some level and in some way, and I think it's important to remind us that the federal poverty level line is drawn at $22,000 of income per year for a family of 4. That's for all of their needs, all of their health care, daycare, new clothes and whatever, food on the table. And in the light of the bipartisan efforts that we've had in the Congress in the past to recognize that despite our differences in opinion on so many things, investing in children's health care is worthwhile. That's the underlying of S-CHIP. The return on investment is also still the case, which Mr. Pallone said. Children continue to be a very affordable group to cover. They represent over half of Medicaid enrollees. They still account for only 1/5 of the program's cost, 1/5. And we've been successful. Between CHIP, Medicaid, and employer-provided health care, nearly 90% of all children now have health insurance, setting them up for healthier, more productive lives and reducing the uncompensated care burden on our economy. Yet all of this would be jeopardized with the possibility of this legislation becoming law. In California alone, it's estimated that the repeal of the MOE will place 400,000 children at risk of losing coverage. Nationally, it could affect nearly 14 million children. This doesn't make sense. When children are uninsured, has already been said this as well, they are likely to lack immunizations, needed prescription medication, asthma care, basic dental care. And not surprisingly, they're likely to miss school due to health problems, experience preventable hospitalization. This has a huge economic impact on families as parents have to choose between their job and caring for a sick kid on $22,000 a year. You don't have a lot of access to daycare. As a school nurse, I can tell you that it leaves these kids very far behind in school. If her ears ache, a young kid doesn't hear well, their ears are ringing, they have trouble breathing because his parents could no longer afford an inhaler. We know how hard it is to catch up once you get behind in school. This amendment simply ensures that if this bill is enacted, we don't go back and lose the ground that we have fought on a bipartisan basis to achieve this. I'm seeing what my governor and our legislature is doing in California, a state hard hit with its economy, making drastic cuts in programs that we all believe in because they have to balance their budget. This is what we will burden the states with. And what they'll do is pass this burden along. They have to balance their budgets so that the burden will be passed onto local jurisdictions, onto county health departments, onto hospitals who will continue to provide the care, more and more of it uncompensated. Providers will see these kids. You know they will. Who's going to compensate them for their care? We're just passing the buck of our responsibility here on to most particularly vulnerable children, and that's why I support this amendment. And I will yield. I will yield to the author of the amendment.
Just briefly, I mean, I think that Ms. Capps is making the point very well. I mean, my point when I was talking, speaking to Mr. Gingrey before is this. You know, I mean, of course, you know, you can always go to the emergency room. You can always try to find a clinic if it's available. I think the emergency room is more likely. But there's no question that several governors have said that their intention would be to simply eliminate kids from the rolls and not provide the insurance. And all I'm saying is when you talk about flexibility, you got all kinds of flexibility under the law right now, whether it's, payment rates to providers, benefits, cost sharing, or even different delivery systems, managed care. A lot of states are putting more and more of the kids on managed care. But all we're saying is that I believe, I'll speak for myself, and I think the Democrats believe, that it's better to have the kids insured. And there's no question that kids will be taken off the rolls if this bill passes, and that's what the CBA is saying, that they're going to be 2/3 of these kids are going to be uninsured. Now, what are the consequences of that? Do they not get any health care? Well, they don't get primary care. They end up getting sick, go to the emergency room. I don't think that's a good way to operate.
Will the gentleman yield? Or the gentleman yield?
Ms. Capps, I don't know if she...
I'm prepared to yield. I wanted to yield to my colleague from Illinois, but she...
Can I ask for time myself?
Okay, then anybody else? I will be happy to yield.
And my friend from California, I appreciate her very much for yielding. But look, what you're doing is forcing states to cut benefits. There's no other way. That's all they can do with these handcuffs applied. They can cut benefits. What we want to do is cut waste, fraud, and abuse to get people off the rolls that shouldn't be there. What's wrong? I can't understand why anybody on your side of the aisle would be opposed to that. And I yield back, and I thank you for the time.
Chair thanks the gentlelady who yields back and recognizes the gentleman from Louisiana, Dr. Cassidy, for 5 minutes.
First, states have these are optional programs. Let's emphasize those children who are currently eligible will continue to be eligible. These are optional programs that the states expanded into when they had the money, and now that states don't have the money, some of them would like to cut back, but it's the state option. And frankly, this is important for the federal taxpayer, but also for the state taxpayer, because as you know, California has a $25 billion deficit. California, your Democratic governor, and I presume Democratic legislature, is looking for ways to do this. But this even begs the question of the argument. You're assuming that if we keep this coverage, that it expands access. This last Monday and this Monday, I will see patients teaching medical residents in a hospital for the uninsured. About 50% of those whom I see will have Medicaid. It begs the question, if somebody has an insurance card, Medicaid, why are they coming to a hospital for the uninsured? They're coming to such a hospital because Medicaid pays so poorly, it doesn't meet a physician's cost, and so therefore they cannot see the patient. That's not just Louisiana. Last year, ironically, just when PPACA passed, the New York Times had an article how in Michigan, a woman with cancer on Michigan Medicaid could not find a provider because Michigan Medicaid paid below cost. The woman she was seeing, her oncologist, was going bankrupt with so many Medicaid patients, she had to leave care. We Googled her. She died a week later. Now, the fact is that what governors and legislatures do, who, by the way, care for their children, you cannot tell me that Jerry Brown and that Democratic legislature in California doesn't care for the kids of California. What they're going to do, presumably because they love children too, is prune back the program where they think they safely can to strengthen the program or at least to preserve it for those who are most at risk. If we pretend... For 20 years, I worked in a public hospital for the uninsured, frustrated because politicians would pass bills, pat themselves on the back, but they were passing bills with the appearance of coverage but without the power of it. Right now, what Sebelius wrote a letter to the states were, listen, if you're going bankrupt on your Medicaid program, just decrease provider payments. Now, subsequently, I think she's a little embarrassed by that. She sent another letter saying you can't do so because she understands that if one of the options they have to continue a maintenance of effort is to spread that pie thinner, then they are going to decrease provider payments, and unfortunately that decreases access. That has clearly been shown when you pay providers below their cost of seeing patients, it hurts access. Now, as it turns out, we on this side think that if you give Jerry Brown and the Democratic legislature the right to make adjustments in their program, they will do it in a way which makes sense both for state taxpayers, federal taxpayers, the unborn who we're borrowing the billions from to finance this budget, as well as for patients, most particularly for patients. I actually have a great deal of faith in your Democratic legislature out there. I think they actually care about children too. So I will say that if we pretend that requiring states which are going bankrupt, that they have to continue this maintenance of effort and we're doing something positive, that we're not negatively impacting other portions of their Medicaid program, or their K through 12, or their social service outreach to the blind and disabled, or anything else that will have to be drained in order to continue to support the maintenance of effort, we're fooling ourselves. Now, by the way, the Congressional Budget Office makes a point that the CBO makes the point that states will abandon CHIP not because they necessarily think it's a bad program or don't have the money, but because they'll go into the exchange. So this bill will not, a CBO's estimate of the impact upon CHIP is kind of a business decision by the states. How do we stretch our federal dollars? They stretch it.
Would the gentleman yield?
No, I'm almost out of time, and then I'll give it to you. So I will summarize by saying that if we ignore the fact that we are leaving states with few options except to decrease payments to providers and other services, we're spreading the same pool of money thinner. We ultimately hurt patient access. We fool ourselves. We feel better about ourselves. But ultimately, it is the patient, the state taxpayer, the federal taxpayer, and our federal deficit that suffers. I yield.
Mr. Chairman. Chair, thanks to the gentleman, and recognizes the gentlelady from Illinois, Ms. Schakowsky, for 5 minutes on the amendment.
Thank you, Mr. Chairman. I won't take full 5 minutes. Mr. Gingrey had mentioned having to cut education programs. I wanted to read some and ask if I could put in the record an email that I got from the National Education Association regarding the statement is to oppose State Flexibility Act. And the quote is, stripping important maintenance of efforts protections from the law would allow states to cut Medicaid eligibility, which would place many of the vulnerable people who rely on Medicaid at risk of losing the health coverage they depend on. This will have a devastating impact on millions of children in our classrooms across the nation. As NEA members are well aware, children who lack access to health care services are less likely to come to school healthy and ready to learn and to succeed academically. The lack of necessary medical services for children and students of all ages creates a serious impediment to the learning process. In addition, families with access to a regular source of medical care are more likely to keep the entire family healthy and create a better learning environment within the home. And so the teachers themselves, teachers across the country, are stating that this would be unwise for the children that we hope will be coming to their classrooms and learning. And if the gentleman
will yield? The gentlelady will yield?
Yes, I would.
I thank the gentlelady from Illinois for yielding. You know, I remind her and my colleagues that 34 states and, yes, the District of Columbia have been forced to make budget cuts since the recession began, and further cuts are projected for 2011. The NEA letter, I'm sure that I'm not surprised that they would be in opposition to it, but because what governors are having to do in the states in regard to these 34 states is increase classroom size, maybe to 30, 35 children in primary classes. They've been able to cut down spending from reducing bus routes.
Will the gentlelady yield?
But I can assure you that the rank and file teacher would probably not agree with this NEA letter. And I thank you for yielding.
I reclaim my time and yield to Mr. Engel.
Yeah, I thank my friend for yielding to me. You know, this is a philosophical difference. It clearly is, and I'm sorry Mr. Cassidy left because I really wanted to answer him, because what he's saying supposes that this is the federal monies that are available and that nothing more is available, and states are cutting because they have to cut, and kids in California, the Democratic governor cares about kids. You see, it's a philosophical difference. You know, we think that having big oil get tax breaks is not something that the federal government should continue to allow. We think that saying that defense spending can never be cut is not something that's plausible. We think the tax cuts for the wealthy are not fair. And so it's not a matter of us not caring about the debt or a matter of us forcing the states to make these tough decisions. We think that my friends on the other side of the aisle just prioritize, and their prioritizing is tax breaks for the wealthy are important, and tax breaks for big oil are important, and GE paying no taxes is fine, and defense can never be touched. Well, we think those things have to be adjusted. So there will ultimately be monies to close the deficit and also to fund these kinds of programs, which we know are very, very important. So, yes, if you have that philosophy that we're going to balance our budget on the backs of seniors, on the backs of children, on the backs of women, then fine. Then what you say is true. But we happen to think that that's not where the cuts should come from. Yes, there's got to be belt-tightening. Yes, there has to be some kind of cuts, but not the kinds of cuts that my friends on the other side of the aisle want to see. So it's really a philosophical difference. There's nobody on this side of the aisle that thinks that we should do nothing about the budget deficit. And, in fact, I'm going to yield to Mr. Wiener. But, in fact, I want to remind my friends that during the years of President Bush, Republicans controlled both houses of the Congress for 6 years. Of the 8 years of the Bush administration. So if they really wanted to do things with the deficit, they really could have done it. So let me yield to Mr. Wiener now.
It's the gentlelady from Illinois' time, but I just want to say in the final 10 seconds, this notion that there's no other choice except to reduce, to cut benefits is not actually accurate. And let's remember something: there are minimum standards in the Medicaid Act today since forever. You can use the same arguments you're using now to say there shouldn't be any of those standards. So obviously you believe there should be minimum standards. You just don't like them being the minimum standards the state of Georgia passed a couple of years ago. It's all of this is about. Now, if you believe there should be no minimum standards, which, by the way, in the debate that originally took place on Medicaid, a lot of people said the exact same thing. Do I have any standards? You've got to have these standards, and if you believe you shouldn't, let's be consistent. Let's eliminate them all the federal standards, and then your argument will be intellectually consistent.
The chair recognizes the gentleman from Illinois for 5 minutes, Mr. Shimkus.
Thank you, Mr. Chairman. I do also appreciate the debate and take it in the intent that we all come to the table on. Just in response to my friend from New York, the drilling expenses was in law in 1911.
Which friend from New York?
It's just my time.
Which friend from New York? You have two friends from New York.
Sometimes it's the same, so it doesn't really. But the drilling expenses was in law in 1911, and if you raise those and you don't raise it on imported crude oil, we just make ourselves more reliant on imported crude oil. And that's not what we want to do in this environment. The tax breaks was tax across the board cuts to every rate level, and we did cut defense in the last CR. I mean, we're making the tough decision. I would ask the question, if a state defaults, what services are paid? The states are not allowed to declare bankruptcy. And states have, historically, there have been states that defaulted. What happens to services rendered across the board if a state defaults? Why am I worried about that? Because I'm from the great state of Illinois, in which 40% of our budget is Medicaid expenses. We are $13 billion in debt. Per capita, we're in a worse per capita position than the great state of California. So the issue is not always, this debate on Medicaid, you all keep focusing on you're going to cut benefits. Why not address eligibility? Why not say, is 350% of the poverty level, should that be figured? Should that... No, there's two sides of the cost and income equation.
Yes.
And when we have this maintenance of effort issue, it does constrain the states into not having the opportunity to be flexible. Medicaid was always created to be a voluntary program. It was designed to be a voluntary program that states could participate with the federal government. It was designed to allow states flexibility. That's why we developed it. All this is saying is let's go back to the intent of Medicaid. Let's allow states to be flexible to address this budgetary crisis, which is affecting across-the-board cuts. As much as we get the debate about where's the plan, you know, even in the Ryan budget, we don't get the balance to, like, what kids today will be 40 years old. The budget, Medicare, Medicaid, Social Security, interest on the debt are unchecked. The only thing, when we fight about the discretionary budget, we're fighting over peanuts. And if we don't address the entitlements, we cannot get control of this. And we'll continue to grow the national debt beyond the historical levels of $4.5 trillion. So this is just the first start to try to say, how do we become more efficient? And we're all from states. We all deal with state reps. We deal with governors. They're going to be held accountable. They're going to have to find new and efficient ways to provide care. They may have to then roll into community health clinics. We may have to address EMTALA. You know, my mom, she's doing well. She went to the emergency room about a week ago. I left my event so I could be with her. I'm sitting in the emergency room. Out of the 10 people that came in, probably 2 were emergent. The rest were twisted ankles, shoulder sprains, and they're using the emergency room for primary care.
Would the gentleman yield, though?
Would the gentleman yield?
I've got some time. And let me go to Mr. Pallone first, since he's trying to get my attention.
But you see, this is the whole point that we're trying to make here, is that we'd rather have the kids covered instead of going to the emergency room. And the gentleman's right. There are alternatives. I mean, one of the alternatives I brought up in my opening statement is FMAP. I mean, when the Democrats were in the majority, we gave money back to the states for education and teachers. We did the enhancement with FMAP.
And
that
actually,
ends next month.
my time,
So
I do.
If you want to do that, I mean, look.
I'm a big FMAP reform guy, since we're a 50-50
But recognize the fact that you still have the recession.
But in reclaiming my time,
something needs to be done, and this is one alternative.
Trying to reclaim my time, I would say that Medicaid recipients use the emergency room more than the uninsured. And that we have to have that reform of this system if we ever want to get to somewhat of fiscal sanity at the state level and the national level. And I apologize for my friend in New York. I'm out of time.
Yeah, the chair thanks the gentleman. I'd like to get to a vote on this bill. We've got 2 more amendments.
Mr. Chairman.
Is there other discussion on this?
Mr. Chairman.
The gentleman from New York, Mr. Engel, is recognized for 5 minutes on the amendment.
Thank you, Mr. Chairman. The point I was trying to make to my good friend is that you look at cutting as the only way to be fiscally responsible. We think there needs to be cuts. There has to be cuts, but we don't think that's the only way to do it. If you give the states a smaller pot of money, of course they have no choice but to make these cuts. But we happen to think that there are some priorities, and we think that these programs for health care are the priorities. You know, when you go to the emergency room and you have people with shoulders and all the things that you described, I mean, they're there because they don't have insurance. They're not insured. And that was one of the premises of the Affordable Health Care Act. We wanted to try to insure as many Americans as we possibly could, and the estimates are that we will insure 30 million more Americans under that bill. We don't want people to use the emergency rooms for those kinds.
Will the gentleman yield?
Let me just get my thought out, and then I'll be happy to yield. So we're saying that there's got to be more than just cutting, and it goes back to what I said before in terms of the philosophical, differences. Somebody mentioned the Ryan bill. I just don't think that we should just get rid of Medicare and Medicaid and turn things into a voucher system or a block grant. You guys do. I mean, I don't think so, and I think there are other ways of tightening our belts, and there are other ways of doing it. And I agree that both parties have been negligent in the past with doing it, and now we cannot kick the can down the road. but not to fix it the way you guys want to fix it on the backs of people's health care, to say we're opposed to the health care bill that we passed and signed into law, but that gives 30 million more Americans coverage. We're opposed to it, and we're going to make burdens even more plentiful on the states, and there's no maneuverability. The only maneuverability is just to cut. That's your philosophy. I'll yield to Mr. Waxman.
I thank you for yielding, because there's a lot of flexibility at the state level. I think Dr. Cassidy mentioned that the states don't have the ability to maintain the integrity of the program. Well, that's not accurate. States may change certain eligibility methods and standards to protect Medicaid program integrity when new eligibility loopholes are exploited in areas. Several members have said that the provider payments are so low. Well, you give the states more flexibility, that's not going to raise the provider payments. They're going to reduce the provider payments and take people out of the eligibility, especially children. Right now, we're talking about children. The Pallone Amendment is an amendment saying we're not going to allow children to be dropped, just children. We'll get other amendments on other subjects. The interesting argument was made by the gentlelady from Washington that when we have low provider payments, they are subsidizing health care for the poor. Well, I suppose that's true, but if you take a child and make him no longer her or him no longer eligible for the Medicaid program, no provider is going to want to take that child without any reimbursement at that point. Some doctors
will the gentleman yield just...
No. Some doctors will, but most won't. So the flexibility that the Republicans are asking for is a one-way flexibility to reduce the kids that would be covered under this program. I think we could look at other alternatives if we're concerned about state budgets, and I'm really touched by all the concern about California's budget. My governor has not signed on to this letter that the Republicans put forward saying that we ought to pass this bill. But we're struggling. Other states are struggling. That requires, it seems to me, more federal help, because I believe a child born in any state in this country ought to have the opportunity to go as far as that child's talents will bring her or him. And that means to me there ought to be a basic standard for health care, not no health care for a child in Georgia where there's health care in another state. And I want to correct another statement that was absolutely inaccurate. No state allows children to be covered or others to be covered under Medicaid when they have an income of $90,000 a year. That sounds good, but it's just not true. So I thank the gentleman for yielding me time to make a few extra statements.
Is there further discussion of the amendment? If there's no further discussion, the vote occurs on the Pallone Amendment. All right. We'll ask the clerk to call the roll.
Mr. Burgess?
No.
Mr. Burgess, nay. Mr. Whitfield? Mr. Shimkus? Mr. Shimkus, nay. Mr. Rogers? Mrs. Myrick? Mr. Murphy? Mrs. Blackburn? Mr. Gingrey? Mr. Gingrey, nay. Mr. Latta? Mr. Latta, nay. Mrs. McMorris Rogers? Mrs. McMorris Rogers, nay. Mr. Lance? Mr. Lance, nay. Mr. Cassidy? Mr. Cassidy, nay. Mr. Guthrie? Mr. Guthrie, nay. Mr. Barton? Mr. Upton? Mr. Upton, nay. Mr. Pallone? Mr. Pallone, aye. Mr. Dingell? Mr. Dingell, aye. Mr. Towns? Mr. Engel? Mr. Engel, aye. Mrs. Capps? Mrs. Capps, aye. Ms. Schakowsky? Ms. Schakowsky, aye. Mr. Gonzalez? Ms. Baldwin? Ms. Baldwin, aye. Mr. Ross? Mr. Ross, aye. Mr. Weiner? Mr. Weiner, aye. Mr. Waxman? Mr. Waxman, aye. Mr. Whitfield? Mr. Whitfield, nay. Mr. Murphy, nay. Mr. Rogers? Mr. Rogers, nay. Mr. Pitts? Mr. Pitts, nay.
Are we voting on the floor yet?
No.
Okay. Okay. The clerk will report the vote.
Mr. Chairman, on that, there were 9 ayes, 13 nays.
The amendment is not agreed to. Are there further amendments? Ms. Capps is recognized.
We have an amendment at the desk.
The clerk will report the amendment.
V02A.
O2A. An amendment offered by Mrs. Capps of
Without
California.
objection, the reading of the amendment is dispensed with. The gentlelady is recognized for 5 minutes in support of her amendment.
Thank you, Mr. Chairman. My amendment will ensure that seniors and individuals with disabilities are not dropped if this bill is enacted. As we know, Medicaid is not just a program of children and poor families. In fact, the Medicaid program is absolutely critical for the health of seniors, individuals with disabilities, and their families. 16 million Americans who rely upon this important program. It fills in where other programs fail, allowing them to live in their community while receiving home health care so they can experience more independence at a much lower cost to them and to taxpayers. It allows for them, Medicaid, to be cared for in nursing homes, care that is prohibitively expensive for most Americans, but particularly out of reach for our poor seniors. In my state alone, Medicaid provides this critical care to nearly 2 million seniors and persons with disabilities. Individuals who have one less thing to worry about because they know they have a way to pay for the care they most desperately need, individuals and especially their families. But the Republican majority's plan today is to take away that security and in many cases leave these low-income seniors to fend for themselves. This burden could leave them with no other choice than to enter expensive and restrictive nursing home care, or it could simply drive them to homelessness. Just picturing a frail and forgetful senior homeless in this country makes me cringe. This new burden the Republican majority is willing to place on seniors and individuals with disabilities does not stop with the patient. In fact, consequences of this reckless action would extend to their families, to their communities, and to our local economies. The rollback of the maintenance of effort provisions could lead to direct harm to these vulnerable populations. First, for those who are in the Medicaid program and are above the absolute minimum means test for coverage, a vote for this bill is a vote to allow them to lose their care completely. In raw numbers, that represents over 5 million individuals who will be at risk of losing their coverage. Second, if someone qualifies for the bare minimum level, the poorest among us, there are still consequences. The bill would allow states to take away in-home care and community-based services that allow them to stay at home for a fraction of the nursing home price, and often with a better quality of life. In California, again, this represents 500,000 individuals who would be left with only the option of nursing home or nothing. In addition, the states could impose onerous enrollment and recertification processes, requiring long waits at the social service agency, increased paperwork, and burdens to find adequate transportation to do all of this. People will naturally fall out of the program, not because they don't need it, but because we allowed for hurdles too high to jump. And finally, I can't help but think of the larger impact of this misguided bill, the impact on communities and families. Earlier this year, we had a hearing on long-term care issues. Members on both sides of the aisle acknowledged the high cost of this issue, both on the individual and on their family caregivers. It seems particularly unwise now to force more people into the situation where they have to choose between going to work and caring for a relative who has lost their Medicaid coverage. We call this the sandwich generation often because some Many times these are families with children to look after. We've been talking about children in the previous amendment, but they also have elderly parents who are much on their minds and requiring their care and oversight. And that's why I've introduced the amendment before you. It's very clear. It simply ensures that seniors and individuals with disabilities who would qualify for medical assistance for nursing facilities or home and community-based services are not dropped if this bill is enacted. It makes clear that we will be determined not to allow these vulnerable groups to be hurt by our desire to play politics with health and well-being. So I urge my colleagues to think about their constituents for whom this program is so desperately important. I urge a yes vote on my amendment, and I yield back the balance of my time.
Chair thanks the gentlelady. Is there further discussion on the amendment? Chair recognizes Dr. Gingrey for 5 minutes.
Well, Mr. Chairman, thank you. And I'm not going to take 5 minutes to voice my opposition to the Capps amendment. I have great respect for the gentlewoman from California, a registered nurse, a health care professional before coming to Congress, and I understand the compassion in her heart. But look, you know, once again, what the Democrats with the previous amendment, this amendment, probably the next amendment, they want to say that Republicans with this particular maintenance of effort disregarding that section of Obamacare, they want to hurt the poorest, most vulnerable, young, pregnant, and disabled Americans. Nothing could be further from the truth. Nothing could be further from the truth. We just simply want to say that those in any of those categories who can afford in these tough economic times, that they can afford maybe to do this through their work, to say to a governor or example or a state, well, you know, you can't look at the rolls very carefully. You can't ask the proper questions. You can't make sure that all income is counted in regard to eligibility. Oh, you work on Saturdays. Well, you know, we're not going to count that as income, you know, so we're going to make you eligible, whether it's 350%, 400% of federal poverty level, 185% as it has been in our state for the Medicaid program for many years under 1115 waiver. We're just simply saying, look, let the governors in the respective states be the incubators, be the pilot programs. Look and make sure that those with the greatest need have a health care benefit that's worth something. As my colleagues have said earlier, what good is having a Medicaid card if you can't find a provider and you have to show up in a charity health clinic or under EMTALA in the emergency room and be treated by a hospitalist who knows nothing of your family history or your prior medical history. And when you get out of the hospital, if you're a kid, a young child, elderly disabled, then who's going to get that information? Who's going to take care of you after the hospitalization? Nobody.
Would the gentleman yield?
And I will yield. Absolutely.
Thank you. Thank you very much for yielding me time, Mr. Gingrey. You know, I want to just remind us that we did have, it's being called our hearing on this topic, but we had Governor Barber here saying that he was determined he would not drop children and pregnant women from his Medicaid rolls. But who is that left? Who's left and who is by far the largest share of Medicaid expenses are seniors. And let's not forget the substantial number of individuals with disabilities who are covered in states by Medicaid for whom there is no protection for their end-of-life care, or talking about seniors now, and for those with disabilities who seek to have additional care than they can be provided at home under Medicaid. What is I would pose this to you, Mr. Gingrey, or anyone on the other side, what's the alternative for how they're going to seek care if this program, they are dropped?
Reclaiming my time, and I yielded a minute to the gentlewoman from California, gladly. But again, as I've said earlier in the previous amendment, Mr. Pallone's amendment, when Mr. Weiner said, well, what is your plan? Well, our plan is just simply go back to what we originally allowed our states to do, to be granted in some instances, maybe be denied in some instances by CMS for an 1115 waiver, to expand the coverage, be more generous if you will. Those waivers, by the way, are supposed to be revenue neutral. I'll guarantee you they're not revenue neutral. So, when it's time to tighten the belt, let's let the governors tighten the belt if necessary and preserve a good program, whether it's S-CHIP for our children, our needy children, our neediest children, or the Medicaid program, so we can preserve a decent program and provide the things that they need, not deny dental care, not deny of vision care, not to deny things that we want to do, but we can't if they're handcuffs as they are with this maintenance of effort provision in Obamacare. We just simply say repeal that section and allow the governors the freedom to not only balance their budgets and not cut deeply into public education and public safety, and provide a health care benefit for our children, our elderly, and our needy disabled. And I yield back.
Chair thanks, gentlemen, and recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes on the amendment.
I think the gentleman from Georgia is being disingenuous when he says his plan, Republican plan, is to go back to what Medicaid used to be before this maintenance of effort provision was put in. The Republican plan, in the budget they adopted in the House, is to block grant Medicaid. It's to reduce the federal dollars for Medicaid. Now, we're saying in the debate here on the Republican side of the aisle, we just can't afford these things. Don't you think the governors are going to say the same thing to people who are going to be permitted to be dropped from insurance coverage under Medicaid? The CAPS amendment would protect seniors and individuals with disabilities. These are people who need nursing home care or home and community-based care. They're not going to get that care under their private insurance. They're not going to get that care at their job in the insurance that's covered while they're employed. This is something that they're eligible for when they are absolutely poor and you don't have private insurance to cover this. Medicaid provides care tailored to meet the needs of this very vulnerable population. For example, Medicaid provides care for activities of daily living, such as dressing, eating, using the toilet, showering. No private insurance, unless it's a long-term care insurance plan, covers that, except in the circumstances where they might be covered for a short-term stay after a hospitalization. 49 states in the District of Columbia have coverage allowing people to live independently. These are the people that the CAPS amendment would protect. The gentleman from Georgia said we want to let the governors in the states be able to count income in a correct manner so that they really are poor enough. Nothing prevents that from happening under existing law. What the Republican proposal is to reduce the maintenance effort now and then reduce the amount of federal dollars for Medicaid next, and then have the governors say, we love you, we care about you, it's so sad that we have no choice. And when these people are dumped from insurance coverage, they have nowhere else to go. They just have nowhere, they have no other options. Private health insurance doesn't cover them. And nursing home care, if they're looking at, they're asking their families to help pay for it, costs $72,000 a year. Assisted living facilities averages $38,000. Home health care services averages $21 an hour. Few people who would be eligible anywhere in this country have that kind of money. It's time to stop this attack on the seniors. And when the gentleman from Georgia says that we want these people who are vulnerable to have less coverage, nothing could be further from the truth. I think that's a statement that is not an accurate statement. These are the people who would be protected if we adopt the CAPS amendment. If we don't, they are standing in line to be the victims of the cuts that are coming down the road. And I have a minute and a half if anybody else wants it. If not, I'll yield it back.
Chair, thanks, gentlemen. Is there further discussion on the amendment? The gentlelady from Washington, Ms. Morris-Rogers, for 5 minutes is recognized.
Thank you, Mr. Chairman. And I've heard my colleagues on the other side of the aisle say that states currently have flexibility, but I would suggest the states do not believe that they have enough flexibility if they do have flexibility, because they are asking for more flexibility when it comes to the Medicaid program. As we think about the future of Medicaid, I've been meeting with a number of disability groups to look for ways that we could improve the program in the way that it delivers services to those that are most vulnerable, those that are with disabilities. And you know, many say will agree that this program is flawed, that it could be improved. And yet I hear on the other side that there's this, that it's as if the program is set in stone and this is the way that it serves them best, and there's no willingness to look that there might be ways that a program could be improved to actually meet the needs of the most vulnerable, those that we are intending to provide that safety net.
Gentlelady,
I can't help but think back to welfare reform.
What do you
in the
suggest?
mid-'90s, with welfare reform, what we did was we gave the states the flexibility to set up programs in a way that would best meet the needs of the poor. And we gave the states flexibility to provide them transportation, education, child care. But it wasn't, this is the amount you get to spend for each category with no flexibility. And I would submit that welfare reform has been a success. People have been better served. They were given the opportunity to be independent, self-sufficient. That should be our goal when it comes to Medicaid too, not confining them to a program that is really limited and does not give states flexibility to truly meet the needs at different times.
Gentlelady,
so,
would you yield?
I suppose so.
When Medicaid was first adopted and seniors and disabled people became eligible, they were only eligible for nursing home care, which meant that we pushed people to nursing homes who really didn't want to be there, and it didn't need to be there because it's cheaper to care for somebody at home or in an assisted living facility or at a daycare centers for a couple hours a day. So over the years, Medicaid has changed to try to meet these needs.
Yes.
And I just want to say that to you because you expressed the concern that we're not willing to try to figure out how to make this program serve those needs more effectively. We do want to work with you on that. I think we have a disagreement because if you give the states the flexibility to cut these people off eligibility, many of us fear that that's not an improvement, it will be a retrogression. That's a difference.
I agree with your comment about community, home-based care. That is a great example of improving a program. I believe that this program could even be improved more. And I also believe that the states, if given the flexibility, we might be able to come up with better ways to meet the needs of the most vulnerable. I don't believe that the states are going to quickly cut people off. What they're going to try to do is determine how best to provide that safety net. And I believe that that is better done at the state level than a federal government top-down, this is the way that it is, with little or no flexibility.
Would my
And I
colleague
yield back.
be willing to yield?
Sure.
Thank you very much. And I just want to pick up and go into this at great length because it's a whole other topic. Long-term care is what my colleague, Mr. Waxman, brought up. And actually what we're talking about here, no one is saying that this is the optimum long-term care solution, the way we have handled adults having to spend down so that they qualify for Medicaid, so that they can have this security of life at the end of their time. Long-term health insurance is prohibitive in cost for the way we treat it. To me, we're talking about something that gets us to 2014. There are many aspects of the new health care law that bring us to the point where we can, with flexibility to states and communities, come together around ways of providing what I've long championed from my role, both living in a community and being a health professional, is a continuity of care for people as we age, as we become more frail. So there are supports in place that should really be designed by communities to provide the needs that they can do this, and with the kind of resources from every level of government to assist seniors as they get into their old golden years. We've not done this. It begs for us to deal with this in Congress. I believe the health care law is one step in this direction, but we need to get to the point where we can see how it unfolds. I want to underscore what my colleague said about Medicaid. When it was first enacted, it only allowed for nursing home care, and now we have seen over time. So all of these things over time will be examined. We are an aging country. People are living longer. We need to address the needs of people as we age. This legislation will do harm now, in my opinion, and in the opinion of those of us who've been offering amendments, particularly now as I offered this one on behalf of seniors.
In reclaiming my time, I would simply say that what our bill would do is allow Medicaid to be more of a design by states. You talked about long-term care being designed by communities and it being a success for the communities to be able to have the options of in-home or community care. What we want to do is provide design by state Medicaid options. And I yield back the balance of my time.
Chair, thanks, gentlelady. Recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes on the amendment.
You know, again, I'm not trying to be critical of the gentlewoman from Washington in that, you know, I understand that she has an approach here, but part of my problem today in listening to her and also Mr. Gingrey is that it seems like they think that Medicaid itself is the problem. I mean, Medicaid isn't the cause of the budget problem for the states. It's the level of unemployment, it's the recession, it's the lost tax revenue that has caused these fiscal challenges for the states. And, you know, Mr. Gingrey keeps mentioning education. I mean, I would remind the other side that when the Democrats were in the majority, we had the FMAP program that basically gives an enhanced match to the states' Medicaid for Medicaid. We had the program that gave money back to the states for teachers and for support staff for education. I mean, there's a very simple answer here, which obviously the Republican leadership doesn't want to do, and that's simply to lengthen the FMAP program. I think it expires on...
Gentlemen, will you...
No, I want to continue here. I've got a lot to say. It expires, I think, on June 30th. Why don't you continue with it? Same thing if you're worried about education, then do something like we did that previous August, and we gave money back to the states for education. I mean, I guess what I'm concerned about now is I'm starting to hear comments that suggesting that somehow Medicaid itself is a bad program, that it's not efficient, that it needs to be reformed like welfare. You know, I don't want to compare Medicaid to welfare. The problem with welfare, one of the major problems, is you want to encourage people to work. That's not the issue here. In fact, one of the issues when we reformed the welfare program was to make sure that if people worked, they didn't lose their Medicaid. I mean, there's never been an issue. It's not an issue of, you know, people not working or people not doing the right thing for Medicaid. I mean, it's not about efficiency. I would just give you some examples here about Medicaid's efficiency. Medicaid's, here, this is interesting. Medicaid is far less expensive than private health insurance. For children, Medicaid costs 27% less than private coverage, only $900 per year. For adults, Medicaid costs 20% less than comparable private insurance. So now I'm starting to think that what you really want to do is somehow revamp the Medicaid program. Well, it's very efficient. It doesn't cost as much. It's not an issue like welfare. When you talk about Ms. Capps' amendment, which is you know, what I'm here to support at this time, my real concern again is that just like the children, there are going to be seniors and the disabled who fall above the mandatory level. Now, if they fall above the mandatory level, states may, and some have already suggested they will, simply take them off the Medicaid program. And then what do they do? Well, some may just be kicked out of a nursing home, or others that have these community-based programs or home health care programs, which have grown quite a bit and make a lot of sense because they're preventative care essentially, they may be thrown out of those programs. So we're talking about real people here. We're talking about practically what's going to happen if you get rid of the maintenance of effort. It means that the people that fall above that mandatory level may either be kicked out of a nursing home, they're going to have to stay home. If they stay home, they don't get the community health care or the home health care, the personal attendant care that some of my colleagues have talked about. What's going to happen with them? They're either going to die or they're going to get sick and end up going to the hospital. I mean, these are the consequences of what you're doing here today. And again, I'm not suggesting you want people to die or you want them to end up in a hospital, But it doesn't matter because you don't have an alternative. You simply say, well, the states will deal with it. How are the states going to do it if you don't give them the enhanced match, if you don't give them extra money, if you don't provide them with the means to provide for these people? Then their alternative in many cases will be, we will simply turn them loose. Now again, maybe they'll go to the hospital. Maybe they won't all die. But I mean, these are the consequences of your actions. And practically, you may not want to do that. I'm not suggesting anybody wants to do that. But that's what's going to happen. It's an inevitable result of this Republican bill. And that's my concern here. So please.
Would the gentleman yield
Let's
briefly?
support. Yes, certainly.
Just to respond regarding Medicaid being efficient, I would suggest that Medicaid has been abused by many who it was never intended to serve in long-term care facilities.
I
and we all
understand
know
that,
across
reclaiming
this
my
country-
time. I understand there's
and
always abuse. But I'm trying to point out to you that this is a very efficient program compared to everything else, and it shouldn't be compared to welfare, and it shouldn't be suggested that what you're trying to do here today is make the program more efficient. This is about money, and who's going to pay?
Chair thanks the gentleman. Is there further discussion of the amendment on this side? The chair recognizes the ranking member emeritus, Mr. Dingell, for 5 minutes on the
I
amendment.
thank you for your courtesy. I've listened, my dear friends and colleagues, to this debate, and I've had governors in my office to talk to me about this business of flexibility. I happen to know that at this time the country has a very severe economic problem, shared by the feds, shared by the states, local communities. We're all in a very tough situation for money and to meet the needs that we have. But the one thing that I've learned as I've listened to everybody talk about what we ought to do about Medicare and Medicaid, governors have come into my office to talk to me and say we need flexibility. And every time I listen to that, I check it out, and I find by the great horn spoon, the flexibility is flexibility to cut, not to add, not to offer new benefits or new opportunities for care or treatment. Now, we're talking this morning about the most vulnerable of our people. Medicaid is an inherently unpopular and perhaps even obnoxious problem. And the reason is it's a welfare program. It's not something that you buy and pay for like Medicare. Everybody pays something in for Medicare, and they say it's a great program. It's mine. But there's nobody to say that for the kids in S-CHIP, and there's nobody to say that for the people who are old or sick or disabled. So we essentially provide charity for those people. And it's always unpleasant to do this because those are the folk who have the least to speak for them and the most to say, but no way of making themselves heard. So I don't think that this is good legislation. Each state has got these problems. As we have drafted Medicaid and S-CHIP over the years, we have tried to see to it that these programs provide wide discretion to the states. The discretion that is not provided, however, is to cut. And to cut essential parts of the program that we as a matter of national policy have thought should be carried forward. And one of the problems that we find here is that we can't give but so much discretion to the people in the legislatures and in the governor's office because we find they will cut back. One of the reasons that the federal government is in this business is that the states were never able or willing to do what they had to do. And so Medicaid was passed when we had a Democratic guy by the name of, well, he was the chairman of the Ways and Means Committee, Wilbur Mills. And he wanted to have something to substitute for Medicare and something to head off the dreadful threat of a program of national health insurance where people began to pay for this kind of expenditure. Well, we passed it, and everybody said, great, now we're going to solve the problems. And we've heard nothing but criticism from the states and everybody else about this, which was accepted in part by people who were willing to go along with it, not because it was good, but because it was something that would substitute for something that they didn't want a whole heck of a lot more. Now, having said these things, we've already rejected an amendment which said you can't cut the kids. I was chairman for a long time, and for a bit of the interim in my time in holding that job, the then President Bush came up with the idea that we ought to pass S-chip, and by golly, we did. It turned out to be a great thing. And we labored for years to try and get all of our kids covered. Now, the kids, again, are important to us. They are 25% of our population, can't speak for themselves, but they're 100% of the future of this country. If you don't take care of those kids and you don't educate them and you don't give them the health care they need, they're not going to be economic units. They're not going to be valuable to us in a world competition. The case, I think, cannot be made quite so well for the rest of the Medicaid beneficiaries. They're just people who are down on their luck, suffering, and they don't have any way of getting health care. Except they do one thing. They run to the emergency rooms where they get care. Somebody's paying for that, and nobody's going to kid me to tell me that you and I in this room who have health care programs that we pay for aren't paying on that money, because we are. So don't kid yourselves. These programs that we have before us to repeal Medicare or cut back on Medicare or S-chip are simply going to shift the costs around because we aren't addressing the big problem which really bothers us all. And that's the fact that we don't bother to reform the health care system in the United States.
The chair thanks the gentleman. Is there further discussion on this amendment? The gentleman from New York, Mr. Weiner, is recognized for 5 minutes on the amendment.
I'll make it quick. Mr. Waxman's telling me to move on. I just want you know you're in trouble when that starts happening. You know, I just want to echo one thing that was brought up earlier. This has actually been a fairly interesting conversation because I think that perhaps one of my Republican colleagues can answer the question whether there should be any minimum standards required at all in Medicaid. I'm sorry.
Like to answer it.
I feel responsible for that. I would gladly yield to the gentlelady from Washington.
Thank you. And I do believe that there should be minimum standards.
Reclaiming my time. I think that we all do, right? So then the question simply is, are you going to have minimum standards that bind the hands of the governors and make it so that they can't do anything? Or do you have minimum standards that represent something that is necessary so you don't have a race to the bottom? The reason you might have an accelerated race to the bottom in this environment is this prospect that the federal government is going to come in 2013 and 14 and beyond and pick up a lot of the burden. So you can see legislatures and governors not saying it's necessarily the best thing for their people, but it's a way to shift responsibility from the federal, from the state share to an entirely federal share. That's why it was put into the law to begin with. So the question becomes then, if you believe there should be some standards, and we all agree that there should be, the gentlelady from Washington, I believe the gentleman from Georgia probably agrees with that, the only question then becomes, do we want the standards to be what the states have all set, the governors have all set recently? How do you decide what the standards should be so there's not a race to the bottom? Do you choose New York's?
Gentleman, yield?
Certainly.
Thank you, gentlemen. We do agree, and I think Ms. Marsh Rogers just answered you in the affirmative that we agree that there should be minimum standards. And the minimum standards should be set certainly at 100% of the federal poverty level in the original law. We agree with those minimum standards. The 138% of the federal poverty level, expansion of Medicaid, they agree with those minimum standards.
Let me just reclaim. Now, you say 100%. Well, what if we decide, or someone else decides to be 101%, 102%? It's just a matter of what the line is that you draw. And the reason that you need to pick a snapshot of time and freeze it at least until 2014 is because of this new construct that we set up. We don't want to have the law of unintended consequences to say, all right, the states are going to have a race to the bottom. Right now, there's not a national standard, as you know. The reimbursement rate for Georgia is much higher than it is for New York. You know that, of course, that the reimbursement rate is much higher than it is for New York because there's this calculation that the average income in Georgia is lower, so the reimbursement rates are higher. Gentleman, the governor of Mississippi was here complaining about Medicaid. He gets an 80% reimbursement. 80%. That's pretty darn good. I'd love to have an 80%. We don't have it. So what they've tried to do is have a snapshot and standard that reflect the best we can the values of the different states.
If the gentleman would yield on that point, just real quickly. I mean, because the gentleman from New Jersey talked about, well, look, let's just expand the FMAT and provide more federal dollars, a higher percentage of federal dollars, and all is well. Yeah, all is well. We borrow more money so that we can expand these programs to cover more and more people.
Hold on a quick
we have
second,
more
Harry.
debt. We have more interest.
Well, yeah, but let me reclaim the time. But you've got to realize that I hope the gentleman from Georgia understands it's not about whether we pay for health care. It's not whether we pay for these services. It is how. Do we do it in an efficient, low way, or do we do it in an inefficient way? The gentleman from Illinois, whose constituents are here, and I just want to tell you, you've got an excellent member of Congress. The gentleman from Illinois made the point recently that he had an experience in an emergency room where people who didn't have emergency room care were in that getting that care. So the question is not whether we provide the people in that room with care, it's how we do it efficiently so they're not in emergency room care.
Would the gentleman yield?
Certainly.
We're talking about seniors in this amendment. I would submit in Oregon, 1 out of 5 Medicaid enrollees may not be eligible for the program, but the MOE restrictions prohibit the state from updating its eligibility determination procedures to correct the problem. You said, are we going to do it in an efficient, low-cost way or an inefficient way? And I would say,
well, wait a minute, but
because
hold
of
on.
the lack of flexibility, it's inefficient.
First of all, let's not say lack of flexibility, because you yourself, I think, when you spoke on this, or the gentleman from Georgia talked about the waivers that are often granted. You can't say the administration of Medicaid as a function is an inflexible administration. That can't be said, because all 50 states have dozens of waivers that they always go to states and say, I want to try to come up with ways. And I have to say this in Republican administrations, too. They say they always try to give the waivers. They always err on the side of giving those waivers. The point that I'm making is if we stipulate that there should be standards, is this a fair way to set the standard? And saying the way states have set it today seems like a pretty fair baseline to set it, because we all agree now, believe it or not, I unified this committee. We all agree that there need to be minimum standards.
Chair thanks the gentleman. Is there further discussion on the amendment? If that concludes the debate on the CAPS amendment, the ranking member and I have spoken. We will postpone the vote. We'll roll the vote and take the next amendment. Mr. Engel, do you have an amendment?
Yes, I have an amendment at the desk, Mr. Chairman. Thank you.
The clerk will report the amendment.
An amendment offered by Mr. Engel of New York.
Without objection, the reading of the amendment is dispensed with. The gentleman is recognized for 5 minutes in support of his amendment.
Thank you very much, Mr. Chairman. I want to first say that the philosophical difference here, as we've sat and gone back and forth, is that we all realize we have a limited amount of money, and the question is, how do we spend it? And I think on this side of the aisle, we don't believe that health care should be cut and that people's services should be cut. We think there are other ways of saving money. So I'm disappointed that we're here today to mark up legislation that would repeal protections for our nation's most vulnerable, who rely on Medicaid and CHIP for their health coverage. It seems that every week the majority is proposing legislation that seeks to undermine the social fabric of our nation. First, it was repealing the Affordable Health Care Act. Then it was tinkering with Medicare and our seniors' health in the budget. Now we're considering legislation that would yank health care away from children, seniors, and mothers of dependent children. When are these attacks really going to stop? Preliminary reports from CBO show that if H.R. 1683 is enacted, up to 300,000 additional people will be left without health insurance each year. So my amendment would preserve the eligibility standards for mothers of dependent children. My amendment protects women who have children under the age of 19 from the harms of this bill, exempting them from the repeal of the maintenance of effort for Medicaid and CHIP in the Recovery Act and the Affordable Care Act. It makes me sick to know that if this legislation passes as is, mothers could be dropped from Medicaid, even those at 40% of poverty or less, which which is, by the way, where half the states are now. I just cannot support a bill that would support dropping mothers of dependent children from Medicaid. Currently, the only mothers who have guaranteed eligibility under Medicaid are those in the 60-day period after labor and delivery and who are 133% of the poverty line. But we all know that motherhood does not end with delivery or 60 days thereafter. And I think we can all agree that right now, just because you might fall above 133% of the poverty line doesn't mean that you have access to comprehensive, affordable health care. My amendment would help support the long-term health of not only of women, but also of their dependent children. Data shows that the children have better health outcomes if their mothers are in the same health plan that they are in. I would also argue that a mother who is healthier is critical to the overall health and success of her children and families. Healthy mothers are able to focus more attention on their children's health because they are not struggling with their own. In addition, allowing women access to affordable health care can set an example for children to be diligent about their health, which we all agree is an important lesson. The impact that mothers have on all of our lives is both physical and mental. We all know that a mother's impact is irreplaceable, and we must do all we can to ensure that our children do not bear the burden of caring for an ill mother because she cannot access insurance as a result of this legislation. Nor should we force financial burdens and stress on mothers because they cannot afford access affordable care. I must admit that lately I have questioned the majority's commitment to women's health. Just last week, we voted to eliminate all insurance coverage for women in need of health services and abortion services. Now we're marking up legislation that could result in eliminating insurance for low-income women who have children. This is just wrong. And I would like to remind my colleagues that this past weekend we celebrated Mother's Day. For me, it's a day to reflect on the memory of my mother. I know that I would not be where I am today without her love and care. I believe it's hypocritical for us to honor mothers on Sunday and take away their health insurance on Thursday. So I urge my colleagues to support this important amendment, and I yield the balance of my time.
Mr. I just
yes, I yield to Mr. Pallone.
I just want to say, I know that I had the amendment on children, but I totally agree with the gentleman that the mothers are just, if not more important. I know that my own personal experience in my district talking to people on SCHIP was that when New Jersey only covered children and didn't cover the mothers, that a lot of parents or didn't cover the parents, I should say, a lot of parents ended up not signing up because, not to look at it in a selfish way, but the bottom line is if the parents can't get health insurance, a lot of times they don't bother to sign up the kids. And so I think that the gentleman, in zeroing in on the mothers here, that really is important, and that makes a big difference. So I just wanted to urge my support.
Would the gentleman yield?
Yes, I yield to Mr.
Is it fair to say that a vote against this amendment means you don't like your mother?
Are you asking me?
I just want to make sure we frame.
Well, it might be interpreted that way.
The optimum way here.
I'll let my friends on the other side of the aisle decide that.
The chair thanks the gentleman and recognizes the gentleman from Georgia, Dr. Gingrey, for 5 minutes.
Well, Mr. Chairman, thank you, and I certainly rise in strong opposition to the amendment from my friend from New York. Here we go again. Look at these three amendments. The first one, amendment prohibit states from making any change to eligibility or verification methods for individuals in or needing long-term care services, the elderly, the disabled. The second amendment prohibits states from implementing new eligibility recertification methods or changing eligibility levels for any mother with children under age 19. The third amendment prohibits states from making any changes to eligibility levels or verification methods for Medicaid or CHIP children under age 19. I'm surprised there's not an amendment in regard to and on behalf of organized labor. These are amendments, of course, that are trying to tug at the heartstrings of the American public, but at the same time, they're tugging at the purse strings of 50 state budgets. And with absolutely wanton disregard for the fact that the states are struggling and cannot balance these budgets with raising, as my friend from New York, Mr. Weiner said, what are minimum standards? Well, there are people in this country that need a hand up, if you will, from the federal government, from cradle to grave. They need it. They have to have it. It's not a matter, though, of they could just use it. It would be nice if they had it. And that's where we come in regard to minimum standards and to saying for the federal government to put handcuffs on the governors and not allow them even to question people, to maybe have a better computer system than they had in the past to find out who really is eligible and needs that hand up from cradle to grave, or somebody that's just there gaming the system. It would be nice if we could afford that kind of thing, but clearly when you've got $14.3 trillion worth of debt and a deficit of $1.6 trillion over the last 3 years and on into the future, you cannot afford to do that. Quite honestly, it seems to me, colleagues, quite honestly, it seems to me that this is a giant Ponzi scheme on behalf of this administration in regard to health care, to setting up a system such that the burden of this new health care program, patient protection, unaffordable health care, if you ask me, Obamacare, to get more and more folks into Medicaid coverage and S-chip coverage, so that there will be fewer and fewer of them on the exchanges and be eligible for a federal supplement. And so that takes the burden off the federal government. They get the credit for insuring 10 million more people who were uninsured. But what they've really done is push this burden upon the backs of state government, who are required to balance their budget. And you know what? We're not going to allow that to happen. We are simply not going to allow that to happen. And that's why we're in opposition to all three of these tugging on the heartstrings amendments, because we know that there's a better way. Now, my colleagues brought up the question about, well, all you Republicans want to do is end up with block grants of Medicaid. That's what you want. You want block grants of Medicaid. Well, that accusation is accurate because we think, and the CBO agrees, that it would save $750 billion over 10 years to do it that way, to be innovative and do it that way. But if we could get rid of these handcuffs, and that's what this bill does, striking this maintenance of effort requirement, maybe we wouldn't have to block grant Medicaid to the states. Maybe our governors would, in their wisdom, figure out a way to be able to have a good, decent health care program for the poor, the elderly, the disabled, the children, and not have a lot of people on the program from cradle to grave that can just use it but don't absolutely need it. So my colleagues, I respect you very much, and but again, these amendments, again, tugging at the heartstrings when you know we can't afford this. And I yield back.
Chair thanks the gentleman and recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Mr. Chairman, from the very beginning, Medicaid has been covering mothers and children, and this amendment will simply preserve current eligibility for mothers. It's pretty basic to me. These are the people who are taking care of the seniors and the children. Mothers sometimes need health care themselves, and taking the guarantee of Medicaid from these women is just wrong. Now, I thought we had a pretty revealing view of things from our colleague from Georgia. He says that block grant will save so much money. Well, it does it, according to the Kaiser Foundation, at the expense of 44 million people who will be uninsured. I asked my colleagues not to listen to the same talking points over and over again. We're told already that governors won't cut children, and they won't cut the elderly and the disabled. Now we're being told they won't cut mothers. Well, they're going to have to cut someone, or this bill is totally pointless. I just want to make sure that in supporting the Engel Amendment that we keep the most basic coverage for women and children. and not let that be cut. I'm going to yield to Mr. Weiner.
I thank Mr. Waxman. I just want to, there's something that the gentleman from Georgia has raised several times. I want to make sure we're clear. There is nothing in the Affordable Care Act or in the maintenance of effort provisions that you strike that stops any state from making sure of eligibility. Nothing at all. There's nothing at all that says that the state can no longer see if someone's actually a mother or that someone actually has an income requirement or anything else. As a matter of fact, any anti-fraud thing that you want to put in, the state is absolutely permitted to do. The maintenance of effort provisions in the Affordable Care Act refer to the standards, the standards and the foundation on which the present state law is passed. There is nothing that stops them, for example, of saying your present state law requires 130% of poverty. You've got to submit a tax form or whatever it is. Of course, they can still do that with the and build upon that. They can add. We want to see the 2012 or 11 to 12 tax form. And the second thing I would just say this is that yes, the gentleman is not entirely incorrect. That one of the reasons that we're providing coverage for some of the uninsured through Medicaid is, frankly, the Medicaid program. A poverty rate among Medicaid is, frankly, it's not keeping up with the true actual cost of poverty at this point. And so the idea was to say, you know what, there are people who make 150% of poverty are still pretty darn poor, and we want to make sure that they're there. However, the very strong incentive on every state and the federal government and every employer is to have more people getting employer-based health care going into the exchange because it means they're working, which is the primary way we lift people out of Medicaid, which is the final point I want to point out. Look, we all agreed in my last searing list of questions that we all agree there need to be standards. I think we can also agree we want fewer people to be on Medicaid as a function of the idea we want less people being poor, right? If we have an ideal world, there's not a poverty program because there are fewer poor people. I don't believe necessarily that poverty is going to be on the rise. I believe that at the tail end of Obama's first term and well into his second term, there is going to be thriving employment. You know, we're going to start seeing this because we're going to defeat many of these Republican efforts to stop the economic recovery. But that doesn't mean that we should have no program, and it doesn't mean that we shouldn't try to keep up with the standards that we have. And I hope there are fewer people getting Medicaid, more people getting insurance in the exchange, and more people working as a result of it. But the idea that somehow, you know, if you don't pass the Gingrey Amendment, this underlying law, that you are going to somehow, like waste and fraud are going to increase. And let me go one final point. The Affordable Care Act is all throughout has provisions that are seeking to reduce the amount of waste that there is in Medicare. I wouldn't like there to be any waste in Medicare or Medicaid. One of the things that we do, for example, is we say that now this contract that we have with people, say you're going to get paid very quickly. No, we're going to put a brake on it in certain areas that have been shown to have higher fraud. There's a bounty program to make sure that you have more reporting of fraud. There's all kinds of things in there, and I think that if we really want to have a conversation, you take a look at the Gingrey underlying bill, see any provision in there that reduces fraud. It's like everything else. There is no plan. There is no there.
I'm going to reclaim my time, see if anybody else wants any of it. If not, yield it back. Oh, yes, do you want me to yield to you? I'd be happy to. Young lady from Georgia.
Just in response to the argument about the fraud, it's the MOE requirements that are preventing states from implementing anti-fraud measures. 2 examples. State of Virginia tried to limit the abuse of taxpayer dollars through financial instruments purchased for the purpose of sheltering assets and
reclaiming my time only to
say that
if there's anything that we can do to assure that states have flexibility, and I think they have adequate flexibility to stop any waste, fraud, or abuse, we all could agree on that. And if you have some suggestions further, other than cutting mothers off, then I certainly want to work with you on it.
Chair thanks the gentleman. Is there further discussion on the amendment? Mr. Guthrie of Mr. Kentucky is recognized for 5 minutes.
Thank you very much. I'll be fairly quick, but I was in state government just a few years ago, and Mr. Winter from New York is correct when you're just doing the maintenance of effort for laws that states have already passed. I can tell you Medicaid in Kentucky, and you'll love the FMAP I'm about to describe, did expand Medicaid in the late 1990s, early 2000s when states were growing and money was coming into the state government. Programs would create, and they'd say, people come to you, but this program has only cost 30 cents on the dollar because it's not quite 70 cents federal FMAP to state, but essentially that. So programs did increase. And then when you get to tougher times, which governors are now facing and new legislatures are facing, and they have the laws from previous legislatures that expanded Medicaid programs, they're trying to make it balance. And they're trying to make it balance. The pie can only be so big. You can raise some taxes, I guess, if that's what your state chooses to do, but not enough for the expansion and the growth of Medicaid. So where they're taking it out of, and I know where Kentucky's taking it out of, is higher education. In-state tuitions increase. So the same argument that you're going to have difficult choices to make in Medicaid if you let states have flexibility. Without flexibility, they're making difficult choices on what's going to happen in K through 12, what's going to happen in higher education. And I think one other member earlier said on the other side that was just a priority situation. If you took the president's budget and you go from 35% to 39.5% for people making over $250,000 a year, where it was the limit of what he said in his campaign, you still, if you project it 30 years into the future, I'm 47, my daughter's 17, when my daughter is my age, 30 years into the future, if the traditional revenue coming to the federal government, 18% of GDP, or if you jump into 20, it doesn't make that much a difference, but this is at 18%. Every penny that my daughter pays when she's working will go to Social Security, Medicare, and Medicaid. Every single penny of revenue to the federal government. So we are going to have to address this. We are going to have to address this issue, and talking to block granting back to the states. The budget did do that we passed. It also gave authority to this committee to sit down and say, how do we do that? What standards go forward? How do we manage it? And we do have to we are going to have to address it. If you today got rid of the Department of Defense and everything else that the Appropriations Committee appropriates, we would still have a $250 billion budget deficit.
The gentleman yield on that point?
I'll do that.
Let me just ask the gentleman, just so we have an understanding. Let's assume this bill passes, state has flexibility, and someone gets dropped from Medicaid as a result of that flexibility. Who do you imagine pays for that person's health care, just in your formulation?
What I'm saying is the governors put their programs together. Does it say they drop people? Does it say that they well, I can tell you what we wrestled with in Kentucky. What we really wrestled with in Kentucky were people who were on Medicaid, who used the emergency room. We're trying to figure out how can we address those types of issues. Currently, the governor of Kentucky is trying to put in Medicaid managed care, where he's not trying to take away benefits or access to care, what the scenario you just described, but how we can best do it efficiently and save money for the state. So those are the kind of programs that I would like to see go forward, where we're still covering people, we're still covering the populations that
but if with the gentleman
we do it in a managed care way.
Right, but with the gentleman yield, I'm not sure I heard the question. Let's assume they make a change that leads to a family being dropped from Medicaid to save money because of the imperative that you said. Who do you imagine pays that? Who do you think pays for that care? Or do you think it's just they don't get sick, or do you think that they pay for that out of their own pocket? Who do you think
if the gentleman would yield, I guess I would throw back the question at what percent of poverty?
Well, whatever.
350% of poverty.
No, but you're asking
200% of poverty.
You're asking state flexibility.
What's the income level?
You're asking state flexibility.
Well, I'm just
whatever
asking,
it is. Let's say it's 100.
Is there an income level that we should have for people then to access Medicaid?
Yeah, that's the minimum standard you're trying to eliminate.
My question is, at what level do we then allow people to actually maybe buy their own health insurance?
So you agree there should be a standard?
I think that if you don't consider percentage of the federal poverty limit, if you expand it and you don't give the states the ability to control, you all debate this on cuts. We're trying to address income qualifications, which provide flexibility to the governors to manage their Medicaid.
Can I answer the question? It's a good question.
I would just ask what it would be if you're throwing a question. What would be the salary range?
You can choose any number you want. You can choose 250, 300. If they can't afford to pay for their health care, let's
go back to the other debate on seniors. What about elder law attorneys who hide senior assets through litigation and they never pay into it?
Will the gentleman from Kentucky, you answer my question?
I just did. I'm asking you to give us,
person who's uninsured
is there an income level by which someone would have to pay other than being on the government dole?
Yes.
Gentleman's time has expired.
That was close. You almost had to answer.
All right. Is there any further discussion on the amendment? If not, that concludes the debate on the Engel Amendment. We will now vote on the Capps Amendment, then the Engel Amendment, and then the final passage. So on the Capps Amendment, having to do with long-term care, the clerk will call the roll.
Mr. Burgess.
No.
Mr. Burgess, nay. Mr. Whitfield? Mr. Whitfield, nay. Mr. Shimkus? No. Mr. Shimkus, nay. Mr. Rogers? Mrs. Myrick? Mrs. Myrick, nay. Mr. Murphy? Mr. Murphy, nay. Mr. Blackburn? Mrs. Blackburn, sorry. Mrs. Blackburn, nay. Mr. Gingrey? Mr. Gingrey, nay. Mr. Latta? Mr. Latta, nay. Mrs. McMorris Rogers? Mrs. McMorris Rogers, nay. Mr. Lance? Mr. Lance, nay. Mr. Cassidy? Mr. Cassidy, nay. Mr. Guthrie? Mr. Guthrie, nay. Mr. Barton? Mr. Upton? Mr. Upton, nay. Mr. Pallone? Mr. Pallone, aye. Mr. Dingle? Mr. Dingle, aye. Mr. Towns? Mr. Engel? Mr. Engel, aye. Mrs. Capps? Mrs. Capps, aye. Ms. Schakowsky? Ms. Schakowsky, aye. Mr. Gonzalez? Ms. Baldwin? Ms. Baldwin, aye. Mr. Ross? Mr. Ross, aye. Mr. Weiner? Mr. Weiner, aye. Mr. Waxman? Mr. Waxman, aye. Mr. Pitts? Mr. Pitts, nay. Mr. Chairman, on that, there were 9 ayes, 14 nays. Mr. Burgess. Mr. Burgess, nay. Mr. Whitfield. Mr. Whitfield, nay. Mr. Shimkus. Mr. Shimkus, nay. Mr. Rogers. Mrs. Myrick. Mrs. Myrick, nay. Mr. Murphy. Mr. Murphy, nay. Mrs. Blackburn. Mrs. Blackburn, nay. Mr. Gingrey. Mr. Gingrey, nay. Mr. Latta. Mr. Latta, nay. Mrs. McMorris Rogers. Mrs. McMorris Rogers, nay. Mr. Lance. Mr. Lance, nay. Mr. Cassidy. Mr. Cassidy, nay. Mr. Guthrie. Mr. Guthrie, nay. Mr. Barton. Mr. Upton. Mr. Upton, nay. Mr. Pallone. Mr. Pallone, aye. Mr. Dingle. Mr. Dingle, aye. Mr. Towns. Mr. Engel. Mr. Engel, aye. Mrs. Capps. Mrs. Capps, aye. Ms. Schakowsky. Ms. Schakowsky, aye. Mr. Gonzalez. Ms. Baldwin. Ms. Baldwin, aye. Mr. Ross. Mr. Ross, aye. Mr. Weiner. Mr. Weiner, aye. Mr. Waxman. Mr. Waxman, aye. Mr. Pitts. Mr. Pitts, nay. Mr. Chairman, on that, there were 9 ayes, 14 nays. Mr. Burgess. Mr. Burgess, aye. Mr. Whitfield. Mr. Whitfield, aye. Mr. Shimkus. Mr. Shimkus, aye. Mr. Rogers. Mrs. Myrick. Mrs. Myrick, aye. Mr. Murphy. Mr. Murphy, aye. Mrs. Blackburn. Mrs. Blackburn, aye. Mr. Gingrey. Mr. Gingrey, aye. Mr. Latta. Mr. Latta, aye. Mrs. McMorris Rogers. Mrs. McMorris Rogers, aye. Mr. Lance. Mr. Lance, aye. Mr. Cassidy. Mr. Cassidy, aye. Mr. Guthrie. Mr. Guthrie, aye. Mr. Barton. Mr. Upton. Mr. Upton, aye. Mr. Pallone. Mr. Pallone, nay. Mr. Dingle. Mr. Dingle, nay. Mr. Towns. Mr. Engel. Mr. Engel, nay. Mrs. Capps. Mrs. Capps, nay. Ms. Schakowsky. Ms. Schakowsky, nay. Mr. Gonzalez. Ms. Baldwin. Ms. Baldwin, nay. Mr. Ross. Mr. Ross, nay. Mr. Weiner. Mr. Weiner, nay. Mr. Waxman. Mr. Waxman, nay. Mr. Pitts. Mr. Pitts, aye. Mr. Chairman, 9 aye, 14 nay. 14 aye.
The clerk will clarify.
14 aye,
14
9
ayes.
nay.
Okay, thank you. Is there any other business to come before the committee? If not, the chair thanks all members and staff. This subcommittee stands adjourned.